Yes, I can see it.
Okay, great. All right,
Hey,
so I guess,
Nicole.
oh,
Nicole, it's Kevin O'Hara. I had trouble linking through Zoom, so I dialed in.
okay, no problem. I had trouble in the Zoom too. It finally worked, but no worries. All right, so my screen is shared here. My title did change a little bit. I was the provider account liaison for Highmark Delaware, and now it's switched to the provider account manager. We did have some changes recently in Highmark, and the biggest one is that we're moving to self-service like a lot of other payers are. So my goal here today is to make it easier for you guys to use our self-service. And if you have any questions, I can either answer them now or I can get back to you later, depending on what it is or, what I can find for you. Okay. So here's Highmark self-service. Here's what we're going to be going over. All right. So our agenda for today, we're doing the Provider Resource Center, Provider Data Maintenance, Availity inquiries, provider facing analytics, and then we're going to do some final tips and takeaways. Okay. You guys should get a copy of this as well if you haven't already. All right, so most of you should probably be familiar with this already. This is our Provider Resource Center. You are going to use this as your go-to guide for provider things needed. There's forms in here. There's so many different resources, stuff on claims. I'm trying to think like the most things that people are using for, there's fee schedules on here. The best way to get this so that it has all the information specifically for your practice when you're in network is going to be to access it through Availity. Okay. And I'm going to show you guys where to find that later, but it's underneath the applications in Availity. Now, if you don't have Availity, which most of you should have, you can access this directly through the webpage for the Provider Resource Center. Okay. And it's under Highmark Delaware, or even if you just type Highmark, they're trying to condense this for all states. And then you pick what state is yours, which would be Delaware. And as some of you probably have PA patients too. All right. So I did attach this in here as a link. I won't go through everything, but there's a couple things that I want to highlight. So this is a quick reference guide here. It's going to take me right to a breakdown of the Provider Resource Center. So this is going to tell you everything that the Provider Resource Center has to offer you. So they have contacts. That's a huge thing now, right? Everybody wants to know how to get in contact people. We still have our provider line open. The difference is now is that it's not for claims. And I'm sure a couple of you have experience when you call in for a claim, it redirects you to go to Availity. That's the new process with this claim inquiry. So we're doing everything through Availity. We'll get into that a little bit more in detail later. Our mailing list is a huge thing, guys. It doesn't have to be, like snail mail, right? We're doing the e-subscribe now. And it's really big because all of our updates or directions or helpful tips, they're all going to be on the e-subscribe. I use it myself because it helps me stay in line with everything that's going on. It's really important. They show you the regions here. So again, you can pick a region. You're mostly going to pick Delaware. I'm just going to scroll past this here. There's a search field. You can filter by categories, authorizations, policies, programs. I'm not going to read through everything, but the resources and education tab is huge for you guys. You'll have your manuals there, any kind of directions on how to submit things. I wanted to go down to show you where to, let's see if I can find it here. Right here on under number 2, the news examples. This provider news is what I was specifically speaking about. This is going to be huge for you guys. I highly recommend. I think it's in another point in the presentation too that I'm really pushing this because it even show you with Availity things. If something's new or if something changes, this is where it's going to go. Okay. They also have the medical policies and the reimbursement policies out here. So if you guys have any questions, and the medical policies actually has a contact as well. So if you guys are questioning any medical policies, you can reach directly out to that team. You don't have to go through anyone else. Okay, so use this to.
Hey, Nicole.
Yeah.
I realize, are you supposed to be advancing your slides?
Oh, you can't see. Okay. That's very.
I see it says welcome to the Provider Highmark Resource Center. But I don't see any actual slides.
Yeah, it didn't switch over. Thank you for saying that. I'm just trucking along here.
You're welcome. Sorry, everybody.
No, thank you for saying that. I'm over here pointing to everything and say,
If you're on the wrong screen, I think that's probably what it might be. There
I
it goes.
think it was just the PowerPoint shared and not the actual. So let me get back up here to show you.
Okay.
When I clicked on that hyperlink, guys, this is everything that I was just talking about. I'm so sorry. But the new provider resource center, this is the job aid. And it's literally everything I was talking about is marked here, has the numbers on the side. And it just breaks down the provider resource center for you. So most of you already know how to use it, but let me show you where I was just talking about the provider news. I'm just sorry if I'm scrolling too fast here. Under number 2 down here, this is what I was talking about, the news examples. Here's the provider news right here underneath. So you want to subscribe to that so that you get all of those updates and the availability things that I was speaking of. But that's going to be anything for Highmark, Delaware. I have mine. We set a rule to go to a specific spot in our email. So that's how I set up mine. And I take a look at them once a week. Okay. Even if you did it once a month, it would be better than not looking at them at all for sure. And then there's medical policy right here and their updates. But you also have the medical policy page. And that's what I was saying, that you can directly reach out to that department. Okay. Sorry about that, guys. So I'll leave, this is out here. That's a hyperlink that I clicked into. So it'll be here for you, but just so you get an idea, it breaks everything down for you, where to find it, what it means. Okay, so I'm going to get out of that now. Look, now I'm like, where is my PowerPoint? Here we go. All right, so all I did was click into this and it took me right to that link. Okay. So moving on to provider data maintenance. This is a tool that's out there that is very important. We are required, I feel like I skipped let me go ahead a slide so that we can push this back a little bit. I'm going to go to this slide first here. The Centers for Medicare and Medicaid Services requires Highmark and its network providers that are current, accurate provider data is published in Highmark's provider directory. This has been a huge thing. This has to happen every 90 days. Okay, so if this is not happening in 90 days, you have a chance of being taken off the provider directory. This has happened to a couple providers and they want to know why. A third-party vendor will go out and they actually remove things. So if you hear somebody saying, I think before it was Atlas that was doing it, and a lot of people didn't know that vendor. But now it's very important to make sure, because if not, you're going to be taken off that directory. The things that you're going to confirm, and again, this is from CMS regulations here, is the provider's name, the practice name, specialties, providers not listed at the practice locations where they not schedule appointments, accepting new patients, and then the provider street address and the phone numbers. Really, really important. You can do that right on the provider resource center. And then this is just kind of a snippet of that. I can't even talk today. Professional providers can validate their Highmark provider directory information with the new provider data maintenance, PDM, tool and availability. And again, that's under the applications as well. And I'm going to show you where that is when we get to the availability piece. We're trying to make it as easy possible to go ahead and do that. If you guys have questions for that, just let us know. It's pretty clear cut and dry. You just have to do that every 90 days. I would do it before the 90 days. Okay. Let's skip over that. All right, so availability. We do not have Navinet anymore. Our commercial business has all switched over to availability. Claims is a huge thing, right? Because we're not doing those intake calls now for claims. So availability is our go-to. This is the main page that you'll actually, before you sign in, before you log in, this is what it gets you to. I did put the live link on here that if for whatever reason you're having trouble, this is here. But this is like the main link before you sign on or anything. This is what most of you are used to seeing when you sign in, okay? The biggest thing in availability that I can push for you guys, especially with self-service here, is this help and training. We all use this. The health and training is very helpful. There's job aids in there. There's a search bar that you can actually type in, and it will tell you like what you need, how to get to it. I highly recommend this. Availity also has a direct help. So if you're looking for something and you can't find it, you can reach out to Availity directly and say, hey, I'm looking for a job aid on this. Is that available? And they can direct you where to go. One of the first things that you want to do when you're in Availity is make sure that you're in the correct payer spaces. That's this area right here. The payer spaces, you're going to pick Highmark, Delaware. That way it drops down anything that you want to find related to Highmark, Delaware. If you pick a different payer, you could find different application, different things. You'll see the application screens on a later slide that I have to kind of show you. I keep talking about all these applications and where the area is, but if you haven't seen that yet, you'll be able to see it a little bit further down. Okay. Anything that you have access to on Availity will list here. So you have to be granted access. To be granted access, your, however we want to say it, the account manager will have a dashboard like this, and they should be able to add your job function. So whatever you are currently doing, this can be added by that gatekeeper. All right. So this is for the inquiries. I know all the claims inquiries now. Most of you probably know how to submit the direct one on a follow-up response. Okay, so if you send in a claim inquiry and you're saying this claim did not pay correctly, or whatever it might be, it processed incorrectly due to a certain code or whatever it might be, you're going to pick this follow-up to a previous investigation for the second time through. If you do not pick this, it's going to act like it's the first inquiry that you're doing on this claim. The reason that this is so important, guys, is because when we're doing this follow-up to a previous investigation and this reevaluation to a follow-up previous investigation, when we're picking those in our system, it is actually notating how many times you've reached out for that claim. The third time around, right, we have that 3-rule process now. The first time is just your general inquiry. The second one that goes through, it's going to say, you know, I'm not happy with it. The third time, it gets escalated to a certain department who is going to dig into that a little bit deeper for you. So if you're not happy with that response, you have the option to go ahead and follow up, but you have to pick the same claim and the same member, same data service. Now, a question that usually gets added to that is, well, what if it's a mass issue? What if it's a project that needs to be done? What if it's for authorizations that are denied across the board? We're not asking you to do 3 investigations for every single claim. What we're asking you is to pick one member, pick one claim, pick one data service, and then you can attach a spreadsheet or a PDF document and send that through with, but it has to be for that same claim. So for example, if I have an authorization issue for 1,000 claims, I pick that one member, one claim, I sent one data service, I send that through. It comes back to me. I'm attaching my information. It comes back to me and says, you know, they all processed correctly, authorization not given or something. You're like, well, that's not the case. That I know that an authorization wasn't given, an authorization isn't needed. Then you're going to do that second inquiry. And on that second inquiry, you're going to say, again, this is a problem issue. This is my second inquiry. You're going to do the same data service, same claim, same member. Okay. So I just want to really get that through because I know a lot of providers have been stuck on that recently. All right. Again, here's my little spiel about my provider news, right? I can't push that enough. I did add this just so this actually was notated in a provider news back in July, actually. So I did put this link here, but this will take you to the provider news so that you can see, and it's broken down by month. It's usually toward the mid or the end of the month that they push it out for that month. All right. All right, provider-facing analytics. So a lot of you use Navinet for your value-based reimbursement. Now, this is just for Highmark Network physicians that are contracted in those value-based programs, okay? So provider-facing analytics, here's the path that you're going to get to it. You're going to go in those payer spaces that we saw in Availity. Under applications, you're going to select the provider-facing analytics. From the sign-on page, use that drop down to select your organization and provider. And then you're going to choose this VIC radio button here. That's going to take you to all your normal reports and everything. And I have to say, I use this for my providers as well. It's very useful and it's easy. And we actually right now, I think to the end of January, if you are interested, I would love to hear from you. We have a focus group doing feedback on PFA right now and the value-based or value insight center. So if you are currently using the PFA and you have feedback, way to make it easier, you love it, you hate it, whatever it might be, they want to hear from you. So please let me know and I will get you guys signed up. And it's usually like a half an hour to an hour meeting with them to help us make it a better system for you guys. We're really trying to make this self-service, especially with these value-based reimbursements so that you guys get credit for everything that you're doing. We're trying to design it to make it easier, not harder. All right, so here's just to sum up some things here, guys. Provider Resource Center, Availity. We're trying to make everything self-service easier for you guys. I know it's, it's a bumpy road in the beginning and we get some pushback, especially with the claims. We care about you guys. We're just turning into this new function, this new role. So, be patient with us, but at the same time, if you need anything, reach out and use your service resources that you have. All right. Does anybody have any questions? I know I kind of went fast. Or want to see anything again? Bright and early on a Thursday.
Thank you. Thank you for your presentation. Yes, does anybody have any questions? You can either put them really quickly in the chat box or feel free to unmute your microphone and ask a question. Give everybody a little bit to get their question together if they have one.
Processing it through. And Chrissy, you have my email. Oh, so something come through. I'm sorry.
No, I was gonna say, I will be sharing copies of all the presentations to everyone today, sometime today following the presentations. As long as I have permission from everyone, to share those presentations, then I'll be sending those out. If you don't get them right away, it's because I'm still waiting on a shareable copy or permission to send those out. Yeah, I don't think any questions are coming through, so I think we're okay.
Sounds good. I hope everybody has a great day. And if something comes up, Chrissy, just let me know. You can send it my way. But I hope everybody has a great day. Thank you for having me.
Thank you so much. Thank you for your presentation.
Have a good one.
You too.
All right, bye-bye.
Okay, our next presenter is Health Options. Desiree Charisse, are you here on the call?
I am. Hi, how are you?
Hey, Desiree.
Good morning.
Good morning.
Go ahead and just give me a second to share my screen. I apologize. I am out in the community, so I am in my car. So
No worries.
just give me 1 second.
Okay, we can see your presentation.
All right, thank you. I'm still seeing it okay?
Yes.
Okay, so my name is Desiree Charest. I am one of the provider account liaisons here at Highmark Health Options. Highmark Health Options is one of the 3 MCOs for the state of Delaware for the Medicaid line of business. These are our current numbers for Newcastle County. We have 68,612 members. Kent County is 22,652 members. And Sussex County is 27,520 members for a total of 118,784 members. Just a quick review of our agenda. We are going to go over the new plan for 2025, the Highmark Health Options Duals Plan. Some quick reminders, some updates on the 21st Century Cures Act, and then our EVV information. So Highmark Health Options went live on 1/1/2025 with a new duals plan. And we're just going to review some information on that. So who qualifies for that duals plan? The member must have Medicare Part A, Medicare Part B, Medicaid, and live in Delaware. And there are benefits of being a participating provider. It provides a seamless experience for both our participating providers and our members. The patients will be managed by one care team for both their Medicare and Medicaid plans, and it's providing that gives a whole person approach. And then it covers all Medicare approved services in addition to some extra benefits that are not traditionally covered by Medicare plans. And here are some of those additional benefits that that's talked about on the last page. They receive healthcare coverage plus prescription drug coverage, dental, transportation, vision, hearing services, fitness center memberships, and a lot more. Some of these enhanced benefits include a $208 combined allowance, which can be used to purchase food or over-the-counter medications, transportation. There's 36 one-way trips for those health-related and non-health-related services, so a little bit different there. They do have a $3,000 combined allowance for preventative and comprehensive services for the dental benefit, which cover crowns, root canals, fillings. And then they have the hearing aid benefit, where they get one true hearing branded hearing aid per ear every 3 years. If you want to learn more about those extended benefits, you can click on this link below. So Navinet is the portal that we are using for the Highmark Health Options Duals Plan. When you log in, you will see at the top a Highmark Health Options plan, but you'll also see a Highmark Health Options Delaware Duals Plan. So you should see both of those when you're logged in. If you are not using Navinet, we do encourage you to use it, as it is for both our duals and our health options plans. So this is the duals website. That's a part of our Highmark Health Options website, and it gives you your provider manual, your benefit summaries for your providers, the medical policies, our model of care, and our provider newsletters and updates. So accessibility to care standards. Highmark Health Options Duals maintains standards and processes for ongoing monitor of access to healthcare in accordance with CMS. So providers are contractually required to confirm these standards. So that's where I think Nicole had mentioned it. You should be receiving calls from our vendor that will confirm your accessibility. And if you have questions on that, there's a little bit more information through our website if you click the link below. And that's where we've contracted with the NCQA certified vendor to conduct those audits and assess the provider's network's ability to provide care to our members. So you'll get the calls of scheduling times and wait times. They'll be conducted via phone interviews, and there'll be an after-hours access audit, which includes phone calls to your office during non-business hours to confirm that the protocols are being followed for after-hours recordings, and your participation in this survey is mandatory. For continuity and coordination of care, we have specialist hospital and skilled nursing facilities must ensure compliance with the continuity and coordination of care requirements by ensuring that all of your discharge summaries, consultations, and progress reports are reported back to the member's PCP. And then if a member needs a transfer of medical records, since it's a new plan, that may be a requirement for them. Primary care practitioners are required to transfer medical records or copies of records to newly designated primary care practitioners within 14 days from the receipt of your request from the member or the member's new primary care practitioner without charging the member. And you're required to transfer member medical records to newly designated MCOs within 14 days as well. So fraud, waste, and abuse. We do have a fraud, waste, and abuse team that helps assist our members and our providers. You can report a potential fraud 4 different ways: by phone, by phone, email, online, there's a form, or you can mail a letter or information to the address listed here. And our policies for that are set forth by CMS where it's applicable. And again, there's just some additional content here if you'd like to read up on that. Provider self-audits are required by CMS and the Office of OIG, and they require providers to conduct self-audits to identify documentation errors and potential overpayments. So if you would like more information about that, it can be found on our website, and there's some additional resources here as well. And those overpayments must be returned within 60 days of identification. So just some quick expectations from the provider network in regards to the duals plan. We ask that you adhere to clinical practice guidelines, have efficient care transitions, participate in mandatory annual training, have an annual MOC training and attestation, Keep timely medical record responses, participate in ICT meetings, stay informed, and maintain accurate provider information. The model of care for the D-SNP plan is as a special needs plan. Highmark Health Options Duals is required by CMS to have a model of care. Our model of care is the foundation of care for our management policies, procedures, and operational systems, ensuring coordinated care for our special needs members. The annual review of that model of care is required by all providers, and it can be found on that section of our website, which will be clickable here when Christy sends out the documents. And upon reviewing the annual MOC document, please complete the attestation once you've done that. Member grievances and appeals. A member can file a grievance or an appeal. For any reason, the grievance process does allow members to formally address concerns regarding Highmark Health Options Duals or its participating providers, and a process for members to request a reconsideration of a decision regarding covered benefits is the member appeal. There is a form out on our website for an appointment of representative form, which must be completed if someone is representing the member to initiate the appeal process. There are additional information out on our website for this as well. Provider has a right for complaints and appeals as well. Provider complaints, we have submit through Navinet, the secure provider portal, to address our issues with Highmark Health Options Duals policies, procedures, and administrative functions via the provider complaint messaging center. There's also an option to submit your claims appeals that way as well. Any provider may file an appeal to request the review of any post-service denial. And again, that's done through Navinet. If you're not signed up for Navinet, please make sure that you do go out there, as it's our provider portal. The provider appeals and complaint process is outlined in the provider manual located on the Highmark Health Options Duals website. Again, back to payment disputes. We will review any claim that a practitioner feels was denied or paid incorrectly. These are administrative and billing denials, and please forward all the appropriate documentation in order to expedite the review. And our preferred method is to submit those via Navinet, but you can also fax those payments dispute as well. Claim requirements and timely filings is a little bit different for our duals plan. So all providers are required to report to Highmark Health Options Duals all services they provide for Highmark Health Options Duals members by submitting a complete and accurate claims regardless of the expected reimbursement. Members are eligible to receive D-SNP benefits if they receive both Medicaid and Medicare. Medicare is the primary payer, and then of course Medicaid is always the payer of last resort. So the timely filing guidelines, like I said, differ a little bit. Initial claims is 365 calendar days from the date of service, and providers must bill within that 365 calendar days from the date of an EOB on the primary carrier when Highmark Health Options Duals is secondary. An original bill along with a copy of the EOB is required to process the claim. Corrected claims or requests for review must be received within 365 calendar days as well from the date of the service on the claim. So Medicare Parts A and B cost sharing, and many of you are probably already familiar with this. As a reminder, our dually eligible members shall not be held liable for Medicare Parts A and Part B cost sharing when the appropriate state Medicaid agency is liable for the cost sharing. Providers further agree that upon payment from Highmark Health Options Duals, providers will accept the plan payment as payment in full or bill the appropriate state source, and be sure to follow Medicaid coverage and claims processing guidelines. Balance billing a dual eligible for deductible co-insurance or co-payment is prohibited by federal law. For your claim submission, there's several options. Providers are encouraged, though, to take advantage of our electronic claims processing capabilities, and submitting claims electronically does allow you faster claim submission and processing time. The reduced paperwork, increased claims accuracy and times and cost savings. We do have a payer ID. We've been getting some claims in with the wrong payer ID. Please take note that if you are participating in submitting claims for the Highmark Health Options Duals plan as of 1/1, the payer ID is the 47183. And again, we do prefer electronic, but if you do need to submit a claim, it does go to a different address as well, and that address is listed here. And any claim submitted to the wrong address or with the incorrect payer ID will be denied. Coordination of benefits and third-party liability inquiries. In order to receive payment for services provided to members with other insurance coverage, the practitioner must first bill the primary insurance carrier using the standard billing procedures required by that carrier. Upon receipt of the primary insurance's EOB, the practitioner should submit a claim to Highmark Health Options Duals. And you must follow all authorization and billing procedures, file all claims within those timely filing limits that we just talked about, submit a copy of the primary carrier's EOB with your claim to our company within that 365 days of the primary carrier's EOB, and the amount billed must match the amount billed to the primary carrier. We will coordinate the benefits. Please do not attempt to do that prior to submitting the claims. Our system is set up to do that automatically. So claims payment for ERA and EFT. So there's a couple payment options when you get your ERAs and EFT set up. You have a virtual card payment. You can do EFT, electronic funds transfer, or a medical payment exchange, or paper checks. So PNC Healthcare issues those payments on behalf of Highmark Health Options Duals via the claim payment and remittances service powered by Echo Health. And you must register in order to receive payments electronically. If you've not done so and you're part of the duals plan, please do that. There is a link here on how to enroll. Care coordination support. Our goal for care coordination is to address medically and socially complex conditions by an integration of services to improve the health outcomes and prevent disease. We do have staff available Monday through Friday from 8 a.m. to 5 p.m. at the number listed here to help manage those members' healthcare needs. You can, as a provider, refer a member to care coordination if you feel like you need additional care. It would be for serious complex medical needs with behavioral health or substance use issues, or health-related social needs or social determinants of health concerns. Members can also reach out and get assistance and join a care coordination team if they meet the requirements. So if you have not already joined and you're interested in joining, we do have a link out on our website that you can submit a request to join the network, and it does give you all of the information regarding the Health Options Duals plan that we went over today. So we're going to go back, switch gears a little bit here and go into the Highmark Health Options Medicaid plan with some just reminders. So we do have some provider training available that's out there. There's two different levels to this. One of those levels is the training for authorization entry for population health and other topics. They're available on our learning portal. If you go out to the website under the provider tab, there's an option for training. And when you click that, it says get started, and you register for a platform called BrainShark. So that has different options, critical incidents, what they are, culturally competent care. We do require providers to complete a culturally competent care program each year and attest to that. And then when our members go out and look for a provider, they can choose that they only want to see providers that's completed this program. So it's really important that you go out to our training website, and even if you've done one internally, attest that you've done that so that in our directory, you're coming up for all searches. So going back, I do apologize. There's two options for this with the, and I don't know if it's on a different slide. I apologize. Give me 1 second. Yep, it is. Okay. So we're going to go here first. So with those trainings, you do have an online training program for opioid and ADHD treatments that gives the clinical criteria. So if it's a clinical person taking this training, they can actually get CMEs upon the successful completion. So you would go out again, there's a separate site that's through our sister site of Allegheny Health Network that's done through. And then on the BrainShark that I just talked about, there's one that is non-clinical, where if you go out and do the training on prior authorizations for ADHD and opioid medications, it's a 20-minute training, you're entered into a lottery to win a gift card. So the link is there. And if you want to go ahead and have anybody complete that in your office, it does enter you into that lottery. So two different options, one clinical and one non-clinical there. So going back, we have a partnership announcement on January 1st, 2025. We went live with a partnership with Health Help, which is now going to be the vendor for prior authorization for musculoskeletal, pain management, advanced imaging, cardiology, sleep studies, and radiation oncology. As we talked about previously with the duals plan, also with the Medicaid traditional plan, under no circumstances may a provider bill, charge or collect a deposit from or reimbursement from a member for non-payment by Highmark Health Options for covered services. This has come up quite frequently. We do have a process in place that if you need assistance getting TPL information, you can call our provider services. If you need assistance in getting an EOB to submit to the primary, we can get that to you. Just reach out to us at our provider services team and we can assist you with that. So 21st Century Cures Act, as everybody knows, this has gone live and we're actively working through claims with this project. So for Highmark Health Options, if you do have denials on a Navinet inquiry, you will see the E1344 denial. And if you're getting a paper remittance, you'll see a COB7 denial. Those are specific to 21st Century. And if you're getting those, there's a couple issues that you need to, or requirements to check what's happening and why you're getting the denial. So if you're getting a denial, the first thing you should do is ensure that what you've registered with DMMA is what was billed on the claim. We're getting a lot of claims that come in that don't have a taxonomy NPI address at the group level match with what is registered with DMMA. So if it is not registered, you would need to register it. And there's an option that if you've already started an application to reset that instead of starting a new application. So if that is there, that option is there, please make sure you're doing that because it does backdate the application date to the initial one that you had started. And then if you need assistance with that registration process, you can outreach Gainwell at the number listed here, or they do have an email address that is available. And if you've gone ahead and verified that the information that you have registered is what is billed on the claim and you're still seeing the denial, you would reach out to our provider services team. They're available Monday through Friday from 8 a.m. to 5 p.m. at the number listed below, and they can walk through and see why that claim denied still. So we also are going to talk about a little bit about electronic visit verification, or EVV. What is EVV? So the 21st Century Cures Act requires states to have an electronic visit or verification, or EVV system, to confirm that certain services paid for by Medicaid are being provided. These EVV systems work by requiring the person that's providing the in-home care to log into an electronic system using a phone or a tablet or other device each time they provide care to the member. There's a lot more information on this out on the Department of Human Services website, so you can follow this link here. So there are some requirements that providers should make their NPI billing, make sure their NPI billing and taxonomy and address are registered with DMEs through that DMAP portal that they will be submitting on the claim.
Hi, Desiree. I'm sorry to interrupt you. Can I just ask you to slow down just a little bit?
Sure.
Thank you so much.
Yep. So once an MCDID is obtained, the providers must register that MCDID with SANDATA. So SANDATA is the vendor that the state uses for EVV. And to note, if you've made any recent changes to your NPI, billing taxonomy, or address in DMEs, that will actually create a new MCDID. So you would need to then complete a new registration with SANDATA with that updated MCDID. So this is just our contact provider relations. Provider services is your first point of contact as a provider, as they're more readily available. They are available Monday through Friday from 8 a.m. to 5 p.m. At 844-325-6251. And then here are the list of your provider account liaisons. If they cannot assist you, you would reach out to your provider account liaison listed here. And it does break it out by territory as well as specialist. So if you just please take note of who your actual provider account liaison here is and make note of that. So that completes our presentation. Is there any questions?
So there are a few questions that popped up. One of them came in during the very beginning. They asked if this is a Medicare replacement.
So it's a duals. It is a Medicare line of business plan. It's a dual plan.
Okay. Another one is Health Options Dual Complete has not registered with Change Healthcare. and therefore physicians are unable to send claims through the clearinghouse.
Okay, if whoever has that, if you could send me an email with my email address listed here, I can get that escalated for you.
Okay, another question is, do all Highmark duals have health options as the secondary?
No, they can choose, it could be 1 week, they could have us as the MCO and another duals plan, or they could have our duals plan and another MCO. They don't have to match.
Okay. There's another one. If we are in network and credentialed with Highmark Health Options, will we need to credential with the Medicare Advantage duals?
You'll need to contract with your credentialing transfers over, but if you're not contracted, you would have to get the contract before that credentialing would transfer over.
We have another one.
Sure.
And Desiree, I dropped the link into the chat on how to read or how to enroll for the duals program.
Thanks, Paula.
You're welcome.
Thank you, Paula. Okay, so the next question is, how do we obtain medical guidelines for our procedures under Health Help when obtaining offs the clinical questions and requirements have changed from what they were previously under Health Options? This is specific to pain management.
So all of our policies are out on our website under highmarkhealthoptions.com, and our authorizations should be following those policies. If you're having an issue where it's not, if you can send me an email regarding that, I could get that over to our provider account liaison that handles the pain management area.
Okay, this may be the last question here.
Sure.
What if there is a gap in coverage? Can they be billed then?
So if they do not have Medicaid, if there's then that our policy wouldn't apply to that. So yes, it would be if they had another carrier or another plan, it would be their policies. But if they don't have Highmark Health Options during the time of service, then our policy does not apply to that.
Okay, thank you. Are there any other questions? Okay, and your presentation will be shareable, correct? I'm allowed to share your presentation with
Yeah,
everyone?
we'll get it to you in a different format instead of the PowerPoint. I'll get it over to you in a different format, but it is shareable. Yes. Thank you.
Okay, great. Well, I want to thank you for your presentation.
Yes, thank you for having us.
Okay, everybody. So, our next presenters are from Aetna. Is Krista on the line?
Hi, you guys. Can you hear me? It's Kristen.
Yes, Kristen. Sorry.
No problem.
Yes.
You guys, I just wanted to make sure. I'm going to share my screen now.
Okay.
Oh, it says someone else is sharing. So it's saying, can you please?
Oh, Desiree is still sharing. There we go.
Okay.
She just ended it.
Okay. Try now. And then let me know when you can see my screen.
Okay. So far, we don't see it yet. Okay, it's loading.
Okay.
There we go. Okay, we see your screen.
Okay. Is it clear or is there something? Okay,
Nope,
I got rid of
it's
it.
clear.
Okay.
Looks good.
All right. Thank you, guys. Hello, I'm from Aetna, and thank you, and welcome to the 2025 Medical Society of Delaware Payer Workshop. I'm Kristen Kolb. I'm the Network Relations Manager. Also presenting today is Cloris Wooders, the Senior Analysis Network Relations. On our agenda today, we will be speaking about network management, healthcare professionals' website, Aetna Provider Portal, reference tools, claims, network updates, resources, and at the end, we can answer some questions. The Delaware Network Management Team consists of Andrew Richard, who is our Vice President and Regional Network Lead, Laura Noor, who is our Vice President, Network Management, Our contracting team consists of Kathy Cleese, Director of Network Management, Amy Rice, Network Manager, Deanna Santiago, Network Manager. The servicing team consists of Krista Herbine, our manager, Director of Network Relations, myself, and Cloris Waters. First, we're going to speak about the healthcare professionals website. Here on our provider homepage, we're here for providers. As an Aetna network provider, you can find the tools and resources you need to stay informed and focused on what you do best, caring for your patients. Some important resources here are our clinical policy bulletins and our pre-cert list. We encourage everyone to sign up for the office links. It is really great information, news, and updates for providers. Joining our network. Here on our home screen, working with us, you come to the first selection here and it'd be join our network. That will bring you to our provider onboarding center. Here you can see below, join our network. We are excited that you are interested in joining our quality network of physicians and healthcare professionals. Here you can complete a request, access and continue a saved request for participation. You can also stay up to date. Existing participating providers can update their demographic information. How to speed up the credentialing process. We hear you. We want you to know that Aetna is committed to reviewing your feedback and providing information to make it easier to work with us. Recently, some of you asked about getting added more quickly to our network. What to do before requesting to join the network. Please make sure the following information is up to date in the Council for Affordable Quality Healthcare, which everyone knows as CAQH, to ensure timely completion for credentialing. CAQH ProView application is in reattestation or initial application complete status. Aetna is listed as the authorized health plan. That CAQH ProView includes current provider professional liability insurance and policy information. That it has all the active service locations listed for the state for which the practitioner is requesting participation. And that you include an active current DEA and active current state license for every state in which the practitioner has active service locations. We just want to make a note that effective October 15th, 2024, we began credentialing all individual nurse practitioners, except those who are hospital-based or delegated, to allow our members ease of access to care and align with changing industry standard practices. This does not include the physician assistants, only nurse practitioners. The credentialing timeline. Providers interested in participating start the Aetna.com and click join the network. After that, you proceed through the following schedule. 1 to 30 days, complete the request for participation. Providers will be notified via email if we intend to pursue a contract or if we are unable to accept you into our networks. 30 to 60 days, the local network operations team will reach out to you to begin the contracting process if required. The contract is an electronic document that must be signed through the Adobe Sign process. Please sign and return the contract through the Adobe Sign. 60 to 90 days. Once network receives your signed contract, we'll request that the credentialing process get started. For most states, we use CAQH to obtain your credentialing applications. As we discussed on the last slide, please make sure all data is up to date. 90 to 120 days. Once you have been approved to the credentialing process, Aetna will countersign and return your final contract via email through Adobe Sign. Aetna systems will reflect your participation, effective date, and Aetna members will be able to see your information in the directory. You can now submit claims. Here at the top, existing provider resources, stay up to date. Working together to keep your information up to date. It's important to keep the information current as it can impact the timely sharing of communication and claim payments. Here, you can access Availity. Availity is our sole provider portal. Log in or sign up to get access to our newest tools and resources. Here, you can update tax ID. Use the form if you need to update your tax ID information. You can update your provided data. Update your provided data such as service location, phone number, telehealth services, email, and more. Lastly, you can terminate your contract. Use this form if you are changing participation, relocating to a new state, retiring, or a provider is deceased. Help your practice by providing more detailed demographic information. Good health starts with good provider-patient relationships. Our members are diverse, so when they have the option to connect with providers who share their identity, they might feel more comfortable talking about their health. According to the Journal of American Medical Association, health disparities and inequities are linked to a lack of racial and ethnical similarities or shared identity between providers and patients. For this reason, we encourage all providers to self-identify. Updating is easy. The Provider Data Management PDM tool on Availity allows you to update information about your business and providers. Keeping your information current and accurate by verifying it every month helps our members connect with your care. Making updates in the PDM tool allows you to share information with Aetna and other payers, reducing phone calls to your office. Some other benefits include staying listed in provider directories and avoiding potential claims payment delays. Updating your information is easy. Simply log into Availity Provider Portal and navigate to My Providers and then to Provider Data Management. If you need to add new providers to your practice, you can use Aetna.com. News and insight. Here, you can get our monthly and quarterly updates, 90-day notices, news, pharmacy updates, state-specific, and Medicare updates. Again, we encourage everyone to sign up for office links because that's the best way to get our updated information and news for the providers. We have resources on here, and we have our clinical policy bulletins, different forms, Medicare resources, patients' mental health, education, training, and manuals, and regulations. Our pre-cert information. Pre-cert applies to all benefit plans that include a pre-cert requirement. Participating providers are required to pursue pre-cert for procedures and services on the list below. We have the updated list on our website for the 2025 participating provider pre-cert list and the behavioral health pre-cert list. For Aetna commercial plans, there is no pre-cert required for buprenorphine products to treat opioid addiction. If we need to review applicable medical records, we may assign a tracking number to your pre-cert request. The tracking number does not indicate approval. You will be notified when a coverage decision is made. There's no Louisiana provider, so we're going to search by CPT code. Use our search tool to see if pre-cert is required. You can enter one or more 5-digit CPT codes. This tool also helps determine if a special program applies. Our clinical policy bulletins. Our CPBs explain the medical, dental, and pharmacy services we may or may not cover. They are based on objective, credible sources such as the scientific literature, guidelines, consensus statements, and expert opinions. Here we have our medical, dental, pharmacy, clinical policy bulletins. We have FAQs, and we have clinical policy bulletin state deviations. Our Aetna provider portal. I'm sure everyone is aware of Availity. Here on Availity, we offer helpful webinars that can show you how to set up your account and finding help and training, Aetna eligibility and benefits and pre-cert, using claims management and remittance tools, working with Aetna on Availity, an Aetna pre-cert and follow-up on Availity. We do monthly interactive live webinars, Doing Business with Aetna, and they are the second Tuesday and third Wednesday of every month. There are a lot of different things you can do on Availity. Our claims tool, claim submission, status inquiry, and payment and coding policies. Do eligibility and benefits, EFT and ERA, online explanation of benefit statements, payment estimator, pre-cert, referrals, and reconsideration and appeals. The Doing Business with Aetna webinar is available for new and existing providers and their staff. We will show participants how to locate provider manuals, clinical policy bulletins, and payment policies, how to access Availity and register for live instructional webinars, access our online forums, provider educations. Sorry, can you guys see my screen still?
Yes, we can see your screen still.
Okay, hold on.
A question came in, but we can answer it after your presentation.
See, right now I'm seeing Christy. How do I go back? For some reason, it's coming up with Christy's name. Oh, 1 second. I'm trying to hold on. Let me just try to go back. Can you see it now? You guys can see everything, right? I'm
Yes.
sorry about that.
Yeah, I can see
Yeah,
your
we can
screen,
see.
Kristen.
Okay, it must have
Yeah.
got kicked off. I apologize. I'm sorry, I was on the third bullet here to access our online forms, provider educational bulletin, and our office link updates for provider newsletters. You can navigate to our provider referral directory and Medicare directory, and to update their provided data and much more. This is the second Tuesday and third Wednesday of every month from 1 to 2:15 p.m. We offer different webinars, working with Aetna. Get a supersized overview of how to use the Availity provider portal and work with us, plus trainer tips and tricks to navigate your way. This is the first Tuesday of every month from 2 to 3. Are you involved in the revenue cycle management? This is the claim management using Availity. This webinar is for you. Learn how to use Availity portal to submit, manage, and dispute claims. This is the third Thursday of every month from 2 to 3:15 p.m. Authorizations. If you manage pre-certs, we'll show you how to look up procedure codes that require pre-auth, submit requests, and other key tasks. That's the second Wednesday of every month from 2 to 3:15 p.m. Submitting drug prior authorizations requests using Novologix. Learn how to access Novologix through the Availity portal to submit a specialty drug authorization, initiate National Comprehensive Cancer Network regimen, and check the status of a request. This is the second Thursday of every month from 1 to 2. Okay. We have many resources, and we were talking about setting up for the education training and manuals. And you would do that here by going to our fourth selection down, and then over to the right, you can select the educational webinars. Reference tools. Our provider manuals about our policies and programs. You can view and download our manuals, our office manual for healthcare professionals, behavioral health, EAP, women's health programs and policies, and benefits product guide. And now I'm going to pass this over to Cloris to close out the presentation and speak about claims.
Hey, everybody. Good morning. Can you all hear me?
Yes, I can hear you.
Okay. All right, Christina. Claims and payment and reimbursement. Convenient tools and guidelines to help you get paid faster. Tools that save you time and money. You should get your ERAs, explanation of benefits, and your claim payments, EFTs, electronically, EOBs, receive payments directly to your account, and review claim payments information online at any time. Coordination of benefits. Get timely payments with electronic coordinated benefits, COB, when patient is covered under more than one insurance. Claim payment estimator and fee schedule. Estimate how much your patients will owe for an office visit, or look up how much we reimburse for services. Refunding overpayments, whether we notify you about an overpayment or your office identifies it, we provide simple steps to refunding. Next slide. Tools that save you time and money. Electronic transaction tools, check eligibility and claim status, and send pre-certifications and referrals. Digital member ID cards. Instead of a plastic ID card, your patients may give your office a photocopy or a printed version of ID card or electronic version of ID cards shown on a smartphone or tablet. Please accept these alternate formats. You can get a patient's digital member ID card by submitting an eligibility inquiry on our secure provider website, or the availability ID cards can be saved and printed. Aetna's Signature Administrator. Aetna's Signature Administrator, or ASA plan, enables us to extend our services to additional plan sponsors with PPO plans. Out-of-network benefits. Some of our plans pay for services from doctors who are not in our network. We pay based on a usual customary charge. Next slide. Dispute and appeals. Our process for dispute and appeals, healthcare providers can use Aetna's dispute and appeals process if they do not agree with a claim or utilization review decision. These processes include peer-to-peer review. Aetna offers providers an opportunity to present additional information and discuss their cases with a peer-to-peer reviewer. As a part of the utilization and review coverage determination process, the timing of the review is prior to an appeal in incorporated state. Federal CMS and NCQA requirements. Reconsideration, formal reviews of claim reimbursement or coding decisions or claims that require reprocessing. Appeals requests to change a reconsideration decision, an initial utilization review decision, or an initial claim decision based on medical necessity or experimental investigational coverage criteria. Next slide. Dispute and appeals. To help us resolve the disputes, we need a completed copy of the appropriate form, the reasons why you disagree with our decision, a copy of the denial letter or explanation of benefits letter, the original claim, the document that supports your position, for example, medical records and office notes. Have dispute process questions? You can use these links here to help guide you. I'm sorry, something popped up and I can't see the rest of the screen. Or contact our provider service center. And here's the numbers below. Next slide. Dispute level reconsideration. Within 180 days of the initial claim rework decision. That's the timeline. At the response time frame within 45 business days of receiving the request, depending on the matter, question, and if the review of the specialty unit is needed. Submit online and check the status through the secure provider website. Appeals within 60 calendar days of the review decision. Within 60 business days receiving the request, the additional information is needed within 60 calendar days of receiving the information. Call or see phone numbers above. And here's the address here. The time frame of 180 calendar days or appeal involving utilization review issues or claims issues based on medical necessary or experimental investigation coverage criteria. Next slide. Network updates. CVS. So this is the individual, the Delaware plan. That is the primary care physician Plan providers must be used to receive benefits outside network coverage, emergency only. So this is the CVS Health individual and family plans. This is the 2025. This is the what is it? The quarterly. I'm sorry, I can't see it. I should have my glasses on, right? But this is the marketplace plan, right, Kristen? I think
Yes.
this is right. And so this is the plan that I think Cheryl put it in the chat. She's questioning this plan. But this is the plan here that the PCPs actually is a closed network, right, Kristen? I think it was created for a certain set
Well,
of pharmacy.
Yep, the individual
Yeah.
family plans.
Yeah.
Yep.
So it's a broad network for the specialist provider, but it's a closed network for the primary care providers. They chose a certain set and they assumed all the risk for it. Next slide. Resources. Network updates. So we have Aetna public website, Aetna provider portal. So you can send your updates through Availity. You can call the credentialing line. You have the pharmacy line here, provider services here. Next slide. Aetna websites at a glance. Our provider websites when Availity at Aetna.com are the quickest ways to find what you need. So if you want to go to Aetna.com to add a new provider, review pre-certification lists and tools, review clinical policy bulletins, access the provider manuals, obtain forms, submit general questions. Availity.com, perform existing provider networks, perform existing provider updates, request for pre-certification, review claim payment policies, access member eligibility and claims, obtain EOBs, submit member information, submit member or provider specific questions. Next slide. Member programs and resources. We offer many programs that some of your Aetna patients may benefit from if they qualify. There's no extra charge for them to join. Some of these programs include care management. So we have disease management, case management, end of life, transplant, women's health and maternity, integrated clinical programs or behavioral health, disability, and pharmacy, as well as wellness programs, disease management, Aetna lifestyle and condition coaching, fitness programs for Aetna Medicare Advantage members, Aetna women's health programs, 24-hour nurse line. Okay, next slide. Thank you. That's the end.
Yes.
All right.
Thank you for listening for the presentation. Yep, that's our end of everything we have to offer today. And we are here to answer questions and concerns. And if we cannot, I will definitely bring it back to get answers for any. So
Thank you for your presentation. We do have a few questions that came through in the chat. The first one is, do non-part providers who are contracted for hospital-based services at Delaware hospitals have a way to submit provider update information to Aetna to process claims more efficiently for the Aetna patients?
well, you'd have to be par to sign up through our website. I'm just trying to think. Non-par hospital based, that would come through usually. Is that what the question was? I'm sorry, the beginning was non-par and then what was the rest?
Yes, it says, do non-par providers who are contracted for hospital-based services at Delaware hospitals have a way to submit provider update information to Aetna to process claims more efficiently for the Aetna patients?
But can't they just call the call center?
You can, yeah, they would have
That's
to
what I
call
would
into
thought.
the PSC.
Yeah.
The 1-800 856-0752, that they would have to call in because non-par hospital base would come through usually on a list from that provider group. But
Right.
if they're non-par, I mean, they would have to call the provider center.
Yes. Yeah, they have to call the call center. Right.
Okay. The second question is, how do we get in network with your CVS plan, as we have a number of patients in our practice and they are frustrated that they cannot be seen?
So they were going to have to go to see the primary care physician that's on their ID card. I understand that they were a part of the office. It sounds like prior to the plan change, but that plan is closed for primary care physicians. So they do have a assigned primary care physician on their ID card, and that's the office that they will have to go to.
Okay. The next question is regarding refunds. Why does Aetna send the refund to Cotivity versus reprocessing the claim when processed incorrectly?
I will bring that one back, you guys, because I do not know that for sure. Could you send me that question if you don't
Yes.
mind? Thank you
Okay.
so much. Yeah, anything that we can't answer, if you could send to me, that way I can send it and get answers for you.
Okay.
Kristen, I actually have examples if you need them as well.
Yes, please, please.
Okay. The following question is there a way to get payments in ways other than capitation? My office currently does not get EOBs from Aetna in any form. Also, is there a tool or a site we can go to if a patient fails to report having Aetna in addition to Medicaid or other commercial insurance?
Yeah, I'm confused about that
I'm
one.
not
Like,
sure the question there. Yeah, the cap.
yes.
When you say other than capitation, so if it's an HMO primary PCP, they are capped in Delaware for HMO, but your commercial, your other plans, your PPO and things like that, they would be fee for service and things of that nature, unless someone's totally contracted differently. So that type of question, it could be, I'm not sure what else they wanted to know.
Okay. How about a site where they can go to if a patient fails to report having any other insurance?
They would have to call member services, the patient, and talk to someone of one of the reps at our member at on the back of their card. There's a number they can call for member services.
Okay. Next question is regarding dispute. What is the next level after we have exhausted all our efforts?
So there's a reconsideration, and then
Sorry.
there's a first level appeal, and then there's a second level appeal. Those are the 3 levels of appeal that can be obtained.
Okay, they had a follow-up question to that. How could they find out who their provider representative is?
Okay, so Cloris, do you want to say? So it depends on, are they part of the health
probably
system?
right. It's likely me. If you're not part of the health systems, then it's likely me.
Okay, and who are you? I'm sorry.
Katie. So what's the group you're talking about?
Kathy.
I'm sorry.
Delaware Orthopedic.
Okay, and my email address, you ready? Do you want it?
Yep.
Okay. My email address is Waters, WATTERSC @Aetna.com. Waters with 2 T's, C is in cat, Aetna.com.
Okay. And in regards to my question for the dispute, so if we want, what is after all disputes are done, we still feel this needs to be addressed, and our position wants to do a full peer-to-peer with an Aetna equal provider such as ortho, instead of getting just a response. They want a discussion. How can that occur?
You probably have to email me, and I'll work it out with you.
On our provider website, you guys, actually, you could go on there. Kathy, there's an other, I just don't know exactly where it's at, but there is a place where they can request a peer-to-peer.
True. That's true. Yeah.
Through the website.
Okay.
Yeah.
Thank you so much. Has Aetna opened up timely filing due to the Change Healthcare?
No.
Okay.
Is there a reason not?
No, there's nothing that we were shared that anything with the timely filing has been changed for anything. Was there something that you guys received that was questionable? I mean, what was the questioning of the timely filing?
Well, I mean, we weren't able to get the Aetna remittance devices. So of course, everything fell behind in working the AR. So due to, 3 months of having issues with getting the responses to even post the payments, which then had to be posted manually because they were all on paper. Then we're working our denials and getting denials stating that it's timely now, which
Well, wait, why were you having problems from the beginning?
so when Change Healthcare went down, we weren't getting the remittance advices. All the remittance advices were being delayed. Then everything was on paper. We had to go to Aetna, print out the EOB, and do it by paper. Because in Ability, you could not download the Aetna EOB into an 835 file. So then we had to hire additional staff to post all the money for all plans. It wasn't just Aetna. We were affected by every single plan.
I'm not sure about Change Healthcare and everything like that. So if you could send that, then we
Okay,
can address it.
thanks.
I'm sorry, I'm not really sure of exactly what that scenario is.
Okay, thank you. Somebody mentions here that they're having issues with contracting for pathology. Does Aetna contract with pathology?
They would have to talk to the contract negotiator. So there's people that handle the contracts at Aetna, but there's all different things for that. I mean, there's several different ways we
Yeah, it
contract and things like that.
depends. It depends
Mhm.
on, the
It's just an
professional
open-ended
component.
question.
It could be a professional component issue. Yeah, it depends.
Okay.
Mhm.
Right.
Is there, can they connect with one of you or and to get them with the right person?
What are they part? Are they part of the health system or are they with an individual group?
They did not say here. I just wanted to get them with somebody who could assist.
Right. So
Likely
it's depending
me.
on
It's likely
where
me.
they're at.
Yes,
Okay.
it's likely me. Okay.
Okay.
Mhm.
One more question here. Uh, oh no, that's all the questions it looks like. Okay.
You can always
Thank
send us, you could always email us and let us know what questions there are, and we'll send them out if we can't answer them and get answers for them.
Okay.
See
That sounds
Alex's question. I don't know if we addressed it, but I'm not sure how we would handle that. If the patient did not know what insurance they had, that's something we would just have to work on. I'm not sure what else we could do about that. I know we didn't, get to that question, but I see it.
okay.
Yep.
Well, I want to thank you guys for your presentation. Will your presentation be shareable?
Yeah.
Okay. All right. Okay, thank you so much.
Thank you.
You guys have a good one. Okay, our next
Have a good day.
presentation.
Bye-bye.
Have a good one.
Our next presentation is AmeriHealth Caritas. And our presenter is Renisha Red. Are you here, Renisha? You're muted still.
Good morning, everyone. Yes, I'm here.
Good
My name is
morning.
Rodney Charette. Thank you. My name is Rodney Charette. I'm with AmeriHealth Caritas of Delaware. I am a provider network management account executive for our LTSS division. However, I will be presenting today for you guys, giving you some informative information and some of our new things that we have. Let me share my screen. Let me know when you can see it. Can you guys see it in a good view?
Not yet. Nothing
Okay.
came through yet.
All right. So, sure why it's not showing. Let's try this again. Can you guys see now? It's showing that I'm sharing.
Still no
Hmm.
presentation on screen.
All right, let's see. Yeah.
We can actually just see your camera, so we see you.
Yeah, just your camera. There you go.
There you go.
Is it on now?
It's loading in. There we go. We can see it now.
Okay. All right. Okay. And is it in a slide view? It doesn't look like it's in a slide.
No, we see the PowerPoint. There we go. Now it's just your slide.
All right. Thank you. Okay, so we have some various topics that we will be going over: vision and sourcing, our balance billing members, verifying member eligibility, TPL, some common billing errors that we see, prior authorization process, access and availability, and then where you can locate our account executive territory and assignments. Like I said, these things are information that we see come across and we think that will be helpful for you and be seamless for you to receive payment. But one of the new things that we have to offer this year is our vision insourcing. So as of January 1st, we have introduced our new vision benefit, excuse me, for both children and adults. So Avisis will no longer serve as the administrator of vision benefits for our members. AmeriHealth will now directly manage our vision benefits. And we have carefully curated network through our optometrists and optician suppliers for that. Right. So if you're looking to add these services or vision services, and you would like to join our network, you can do so by reaching out to your account executive, and they will be able to assist you with that. That information for your account executive, if you're not sure, will be, I will share that at the end of the presentation, but it's also listed on our website as well, where you can go out there and click the link and locate your account executive. All right, balance billing members. We do at times get issues where members are being balance billed. We just want to make it known that, no participating provider should be billing members any type of balance billing. So as a reminder, the reference language below from our AmeriHealth Caritas Provider Manual in Section 9 for claim submission and protocols, that under the requirement of the SSA, all payments from AmeriHealth Caritas Delaware to our PAR plan providers must be accepted as payment in full for services rendered. Members may not be balance billed for medically necessary covered services under any circumstances. So we encourage our providers to use the claims provider complaint process to resolve any outstanding claim payment issues. That information as well, the claim dispute process can be found on our website as well. Verifying member eligibility. AmeriHealth Delaware member eligibility, it can vary. As a PAR provider, you are responsible for verifying your member eligibility. And I know at times, there are times that you may not be presented with the correct information, but we're asking that you do as much as possible to verify the information. We have different ways for you to do that. You can visit the provider area of our AmeriHealth Caritas Delaware website. The website's listed here, and you may access our Navinet, and it's a free web-based application for electronic transactions and information, and it's secure. You may also call into our provider services for verification, and it's automated real-time eligibility. You can use that one, or you can also speak with a live representative. So using the AmeriHealth Caritas real-time eligibility, it depends on your clearinghouse or practice management system, and our real-time service supports batch access to eligibility verification and system-to-system verification, including point of service. We do encourage our members to keep their their ID cards on them at all times, but we know there are instances where that does not happen. So we're just asking you to verify. But we do want to make note that AmeriHealth Caritas, we do not get the return ID cards from the members. We don't receive them when the member is ineligible. So presentation of AmeriHealth Caritas ID card is not proof that an individual is currently a member and will not guarantee payment, unfortunately. If you suspect a non-eligible person is using a member's ID card, please report the occurrence to our fraud, waste, and abuse hotline. This information is also available on our website. Our TPO and coordination benefits. So TPO is a financial responsibility for all or part of our members' health care expenses, and the rest with the individual entity. So AmeriHealth, we are the payer of last resort. And so this means that all insurance carriers must consider the healthcare provider's charges before a claim is submitted to AmeriHealth Caritas. Therefore, before billing AmeriHealth Caritas Delaware, when there is a primary insurance involved, healthcare providers are required to bill the primary insurance first and obtain an EOB from the primary carrier. Providers may then bill AmeriHealth for the remaining balance on a claim by submitting the claim along with a copy of the primary EOB. Claim EOBs from the primary insurance carrier, including Medicare, must be submitted within 60 days of the date on the primary insurance carrier's EOB. So we will be looking at that date on the EOB. Any event of an accidental injury, whether it be personal or an automobile, and where there's a third party is deemed to have a liability and makes payment for services that have been considered and paid under the AmeriHealth Caritas Delaware contract, the plan will be entitled to recover any funds up to the amount owed by the third party payer. We do have some exceptions to the primary or to the EOB. So the exceptions are that if the claim is for a prenatal care for a pregnant woman, the EOB is not valid. I mean, you wouldn't need it. If the claim is for preventative pediatric services, including EPSDT, that are covered by the Medicaid program, following reimbursement to the provider in these cost avoidance exception cases, AmeriHealth Delaware, Caritas Delaware shall actively seek reimbursement from responsible third parties and will adjust claims accordingly. Some of the common billing errors that we see is like duplicate claim submissions, our timely filing, authorizations, member termination, and Z11 EOB from primary carrier. So a lot of these can be downsized by checking for the member's insurance, like I just stated, looking at the EOB, getting the EOB to us when you're submitting the claims, checking whether you're going to look at Navinet or call into our PCS services for the members' eligibility. And we also have you have the option to look on our website as well underneath the providers too to see if the code does need an authorization. You may also always reach out to your account executive if you're unsure if a particular procedure code needs to be authorized as well. A corrected claim may be submitted within 365 days from the date of service. Please ensure you are appending the correct resubmission code to your corrected claims to reduce the claim denial errors of duplicate claim denials. Because if we don't see that, their resubmission code, then we will consider it as an initial new submission. So you can do that, and that will help reduce any type of duplicates. Insured claims have not been submitted previously. Insured claims are submitted within the plan's filing limits of 120 days from the date of service. So the initial claim submission should be submitted within 120 days from the date of service and 60 days from that primary carrier's EOB. So after the initial submission, that's when you have that corrected claim. If you have to submit a corrected claim, you have 365 days from that date of service. You can confirm the member's eligibility by utilizing Navinet, calling provider services, or utilizing the state DMES system. Prior authorization process, talked a little bit about this, but AmeriHealth has worked with NantHealth, also Navinet, to bring you medical authorizations. It's a robust and intuitive, streamlined authorization workflow. And in addition to submitting and inquiring about an authorization, you will also be able to verify if no authorization is required, receive auto approvals in some circumstances, submit amended authorizations, attach supplemental documentations, sign up for in-app status change notification directly from the health plan, access a multi-payer authorization log, submit inpatient concurrent reviews online, if you have the health information exchange capability, because fax is no longer required, and review inpatient admission or notifications and provide some supporting clinical documentation. So there are step-by-step video tutorials and instructions that are available via the Navinet plan central page in the NantHealth Help Center. You may also get to the Navinet or NantHealth website also from our website as well. Access and availability. So AmeriHealth Caritas promotes consistent access to care and appointment standards to ensure that our members have timely access to healthcare services. So we ask that our providers meet standard guidelines to help ensure this timely access. And here we just list some things. I'm not going to go through all of it, but some of the things that we request and require is that for the PCP must be available 24 hours a day, 7 days a week. So that means we are asking that the PCPs have either an answering service or a machine for members during off hours for non-emergent issues. And the answer service will forward calls to the PCP or on-call provider, or instruct the member that the provider will contact the member within 30 minutes. So when the answer machine is used after hours, the answer machine must provide the member with a process for reaching a provider. And of course, in all emergent situations, we are going to recommend or encourage the member to call 911 or go to the nearest emergency room. For behavioral, for a general or appointment standard, we request the member should be seen. For any emergent or life-threatening potential suicide, request that there is availability 24 hours a day. Again, it must be available on an immediate basis. For routine outpatient, within 7 calendar days, we request the non-prescribing clinician for an initial assessment, members being discharged from an inpatient or residential setting or placement, or members that were seen in an emergency room. We request a 7 calendar day, within 7 calendar days of a visit. And if it's not emergent, then it should be within 3 weeks of the request for prescribing clinician services. For our maternity care appointment standards, upon request, members should be seen if it's their initial appointment, first trimester, within the 3 weeks, second, within 7 calendar days of the request, and third, within 3 calendar days of request. And for high-risk pregnancies, within 3 calendar days of identification of high risk by the plan or by the provider. No waiting time should exceed 1 hour. There are exceptions. We understand that exceptions occur when a provider works in urgent cases with a serious problem is found. So when a patient has an unknown need that requires more services or education than anticipated at the time the appointment was made, we understand that things may go a little longer than that. When wait times do exceed or extend past the identified exceptions, waiting patients must be notified of the delay as soon as possible. And if the delay is going to take longer than 90 minutes, we ask that the patient be offered a new appointment. PCP should be located within 30 miles from the member's residence. And for these standards, they're listed below. For emergency conditions, within the same date of member request, if possible. Urgent medical conditions within 2 calendar days or 48 hours. And then our routine appointments, we're asking that they could be seen within 3 weeks. The 24/7 nurse call line. The 24/7 nurse call line is a service that members can call 24 hours, 7 days a week. And nurses are available to answer questions and give information when a doctor's office is closed. All right. Do we have any questions? Please note that all information can be located on our website.
Thank you for your presentation. We do have a couple of questions that came in. Let me scroll up to the beginning. Okay, so the first question is, if a patient loses AmeriHealth Caritas for a month and then becomes qualified again, can they be billed for the month that they did not have coverage?
No, from my understanding, they can be. It will pick back up on the effective date of the new coverage.
But what if that 1 month you didn't activate them for that 1 month? So say that they weren't active for the month of July, you termed them on 6/30, then reinstated them on August 1st. and they
So
had
what
services in the month of July.
if they had if they had services in the month of July and they weren't covered by us, those services would not be covered.
So wouldn't we be able to bill the patient?
If they're not Medicaid with us, yes, at that time. But
Okay, so
also,
they're not Medicaid in that month, we can bill the patient.
if the patient is made aware that they're going to be billed as well, yes.
Okay, thank you. The next question is, if a patient has a deductible under the auto PIP, can that be billed to AmeriHealth Caritas?
I will have to get back to you on that one in reference to any co-pays.
Okay.
But I'm getting that they can, but I can
Okay.
get back to you.
Has AmeriHealth opened up timely filing due to Change Healthcare?
So there are some exceptions. It is by a case basis. I wouldn't say that it's opened up. I would encourage you to reach out to your account executive to discuss that with them and provide any support and documentation that you may have.
Okay. A question came in back to motor vehicle accidents. If the patient didn't have PIP, can they then submit the claims to AmeriHealth?
Yes, they can.
Okay. Next question is, what do you use to terminate patients from our panel, and are they then removed from quality reporting purposes?
Can you repeat the question? What do we use to?
Yeah, so I think for the quality measures, if their patient is no longer with their practice, but they show that they are a patient on your end, sounds like that they're asking how do they remove them as being listed as their patient when on your end when they're no longer a patient with them. That way there's no errors when they report for quality measures.
Oh, so they can request them to be removed by reaching out to us. We should already be removing them. If they're not, then you can reach out and contact us so that we can remove them from
Okay.
their panel. Mhm.
The next question is, what is the contact information for our account executive for the Kent County region?
Kent County for medical.
Yes.
Yes, okay. That will be Calvin Sparks, C Sparks at AmeriHealthCaritasDE.com. And you can also find the list on our website.
Okay, thank you.
You're welcome.
Any other questions? Feel free to send me email, everybody. I did put my email in the chat. And is your presentation going to be available to share with everybody here today?
Yes.
Okay. Alrighty then. Well, I want to thank you for your great presentation.
Thank you. Everyone have a great day.
You too. Okay, so our next presenter is from Cigna. Is Catherine on the line?
Yes, I am.
Oh, great. Okay. Screen share is enabled. You can share your presentation. Okay, great. We could see it.
Oh, can you? Oh, perfect. Okay, I'm not Zoom savvy. Good morning, everyone. My name is Catherine Leonard Nixon. I'm a provider relations manager for Cigna Healthcare. I am located within our Liberty Valley region. So my providers include providers on Eastern Pennsylvania, Delaware, and a few that jump over into the New Jersey region. So thank you for allowing me to present for you today. And I do want to apologize. My husband shared the cold right after Christmas, and it's still lingering. So we will get started. Again, our presentation is enhancing our lives together. So we want to improve the health and vitality of those that we serve. We have support at every stage. We have a dedicated service team to support the day-to-day interactions. We provide revenue cycle management support. We provide medical, pharmacy, and behavioral information. We also provide drug benefit information at the time of care. And we do provide personalized digital tools as well as telephone concierge service to guide our patients towards the affordable care that supports their needs. So we're going to talk right now about our delivery system and our network solutions for you. We have access to quality, cost-effective care. We have multiple site employer groups, our strategic alliance, our health partners based in Minnesota, North Dakota, Western Wisconsin. Then we have our MVP in Bradford County, Pennsylvania, and New York. And then we have our Priority Health in the Michigan Lower Peninsula. And I just lost myself there. I'm sorry. Let me go back. Is it showing or not yet? I'm sorry for that.
Yes, we see your screen. It's showing.
Oh, can you see my screen? Okay.
Yes.
All right, because I cannot see the presentation on my end now. Okay. All right, so let me just, I'm going to apologize. Let me stop sharing and try to reshare again.
Okay, yeah, I was definitely going to suggest.
Okay. As I said, we're not a Zoom company, so I do falter at technology, new technology as well. So, okay, there we go. Got myself back. Thank you for the brief interruption.
You are.
Okay, let's see. Then we do also have, we are a global company, so we do have global health benefits for our expatriates as well. And we do have customer service and support 24/7, 365. So that is something that we are very proud of. And let me go into some information on our digital solutions. Right now, we have our digital tools that streamline the office workflow, increase productivity, save time and money, and give you access to patient information when you need it. We have support for the way that works for you. We have our Cigna Healthcare Professionals website, cigna4hcp.com, so you can verify eligibility for a particular benefit. You can look up procedure codes. You can check claim status, upload attachments, submit reconsiderations and appeals, submit pre-certification, pre-service appeals, as well as view any important policy and procedure information. Using one of our electronic data interchange vendors, you can submit your claims electronically, including your coordination of benefit claims. You can receive payment information, status, eligibility, and benefit.
I'm sorry, Catherine.
Yes.
You kind of cut out first. Cut out like you sound far away, Anil.
Okay. Let me see if I can't do my volume here. Is that any better?
No, it's the same.
How is this?
Still the same.
Checking my speaker systems here.
Yeah, the sound sounds like it's pretty far.
Yeah, I'm using my computer audio at the moment,
There,
so.
there we go. It's back now.
Okay, terrific. Thank you. And thank you for bearing with me. Like I said, I'm not the most tech savvy person. So with our EDI vendors, you can receive claim payment information, submit eligibility, request for pre-certification. And then we do have a streamlined payment process. By enrolling in EFT, you can eliminate the paper checks. You can access your funds on the same day as they're deposited. You can view the separate remittance reports and easily reconcile payments using the tracking number. It also reduces your costs and saves you time, decreases posting errors, and shortens the payment cycle. And that information is available through our Cigna for HCP.
Right. Yeah. Oh, it doesn't matter.
If you could please mute your microphone. Somebody's unmuted. Sorry about that, Catherine.
With our easy access to payments, you can save and store the information, make it shareable. You can view the explanations of your claims being processed. It's a little bit easier to reconcile using the EFT report and the information online, and then you can also view each deposit. And that information is all available at our signaforhcp.com. And then we'll talk now about national ancillary providers. We do partner with quite a few national ancillary providers to ensure that we're providing quality and cost-effective care. ASH is, I'm sure, a big one everyone is familiar with, as well as we do have Evacor Healthcare and Evacor Health Services within Cigna. So here's basically the all-inclusive, and I don't want to say all-inclusive, but it's the best case scenario list here for you. And that is breaking it down by category. And we do try to use providers locally within our own neighborhoods so that we have the additional specialty that we'll need so that the patients won't have to travel very far for the services. And that information is available you can verify the coverage and with the ancillary providers on our Cigna for HCP.com or calling into Cigna. Policy updates. We try to keep a lot of our policy updates and information out there so that the reimbursement, the coverage, the administrative policies for the evidence-based medicine, the professional society recommendations, Centers for Medicare and Medicaid Services, industry standards, as well as Cigna other policies. And all of this is available on our Cigna for HCP.com. You would just simply log in or just go to Cigna for HCP.com, even if you don't have a login. And then up in the top, you can actually type in the information you're searching for, or just peruse down to resources, coverage policies, and you can peruse in there for the information that you're looking for with regard to specific services, CPTs, diagnoses, etc. Also review our pre-certification policies available as well on our Cigna for HCP.com. talk about the claim submission and appeals.
I'm
because
sorry, Catherine, your mic cut out again.
Can you hear me now?
We can barely hear you. It sounds far.
I'll try to speak a little bit louder. Is
Okay.
that
Yes, it's back
okay?
now.
All right. Thank you. And thank you for bearing with my technical challenges here. So using our EDI process, you can actually submit your claims electronically via the 837, and you'll receive the payment information on an 835. And this is all familiar lingo and language for you. And just this is kind of promoting the self-service portions that are available to you, and the best way to do that with our Cigna. And then our features, newly designed search capabilities. You can view the claims at an organizational level, creates flexibility, filter your results, and download everything into a report. And then this kind of gives you a little bit of a demo as to how you get in, where to search, where you'll put the patient information in on that screen. And then you can view individual claim numbers, and it will tell you if they're processed, they're denied, the payment information as well, sorting on the various columns and headings. And then it does give you some detailed information on pending claims as far as explanation of benefits. If additional information may be needed or requested, you can get that information as well. And then it does go through and tell you how to submit the information to upload the additional information that we're requesting on a specific claim. And then as well as doing a reconsideration and starting your appeals. This information is available as well, and it does give you a breakdown. And I do have a shareable PDF version that I did send you, Christy, that is available to be shared with the audience.
Thank you so much.
And then our claim reconsideration and appeals, a little bit more detailed information and the step-by-step guidance on, how to do it, what information is going to be needed, and what quality and categories that it falls into. Then next, I'll talk about our resources and our contacts. Like I said, we do have our Cigna for HCP.com. We also do have a provider reference guide, and new this year, we have a provider newsroom. So this will give you some up-to-date information on upcoming policy changes or enhancements that, are in the works. You can actually view provider letters out there as well. So trying to keep up with the modern technology and cut back on our carbon footprint. We're angling for more electronic communications, and these are just some resources that we have available to our providers. We do have our digital solutions team with a resource training page. We do offer some free webinars as well, and that information is available as far as going out and seeing what schedule might work best for you. We are trying to push for the digital ID cards, and with some of our aging populations, it's not as feasible as we would like. So we do try to encourage the digital ID cards, but again, a lot of our providers maybe don't have the necessary equipment either to scan that information in. So we do have some information there as far as how you can actually go out and download and print a copy for a customer in your office, so that you can have an actual copy on file, a screen print of that for you. And then we also have for you to update any of your demographic information. Any of my providers in Pennsylvania and Delaware, I do ask that if you are submitting any requests for demographic changes, new address you need to be added to a provider's profile. You're, aligning them to another TIN in addition to one that they may already be aligned to, any kind of changes, that we do have the email of intake, and it's an underscore. That's not very visible here. _PDM@Cigna.com, that you just CC me on your changes. And this way then if there's any questions, I'll be able to reach out to you or help address any concerns with that. But if you have some providers in the attendance in the audience, and you do have your other designated provider relations executive or provider relations manager, certainly feel free to CC them on any changes or reach out for any clarification that you may have on any of the presentation being presented today. And do you have any questions?
Okay, does anybody have any questions? I don't see anything that came in so far. Okay. Well, if anybody does have any questions following this presentation, feel free to shoot me an email and I will be sure to get those out. Oh, here we go. Got one. How can we find out who our rep is?
Actually, if you, well, that's kind of a tough question. What we can do is I can actually, if you, Kristen can provide you, Christy, with my email, and I can certainly reach out to see who your provider representative may be, and, shoot you an email back and let you know who your representative is. If you don't have a specific aligned representative, then we can actually get you to the contractor for you, who can help assist you as well.
Thank you so much. Okay. So if there's no other questions, I want to thank you for your presentation.
Thank you very much for the opportunity. Take care, everyone. It was a pleasure.
You too.
Thank you.
Our next presenter is United Healthcare, and that presentation is going to be by Tracy Cross. Tracy, are you here?
I have to get myself off of mute. I'm sorry.
Oh, there you go. You're off mute.
Okay, very good. Good morning, everybody. Thank you for coming into the meeting.
And your mic sounds distorted as well.
Oh, does it? Is it sound better or no?
When you speak up, we can hear you.
Okay. Is it still distorted?
It's like a noise in the back. I don't know if it's like a fan or something.
Okay. Is that better?
Yes, that's a little bit better.
Okay. I have my heater on. My toes are cold.
Hi, it's Lynn Robinson. You are still very distorted on my end. There's a lot of background noise.
Yes, I don't know if it's a fan.
Agree.
No, I don't have anything on now. There's nothing on. All right, let me go on mute and then try and come back.
Okay.
All right, is this any better?
No.
Still the same. Yes, still the same.
Still the same. Okay.
Can you call? Is that the microphone on your on your computer?
No, I'm wearing a headset.
Oh, you're in a headset. Okay.
Yeah.
Could you possibly dial in on the phone?
Yeah, let me see. Let's see. I don't have a plug-in headset too. That might work better, so just give me a moment.
Tracy, the background noise is gone. So
Yeah, I
if
was gonna say that too.
Okay. All right. So can you
Here
hear
we
me
go.
now?
That's really good.
Okay. All right. That was so weird. All right. Thank you very much. Let's see if we can get rolling. All right. Can you see my screen?
Yes, I can see your screen.
All right. Is it in presentation mode or is it in
No, it's in PowerPoint.
PowerPoint? Okay. All right. Is that better?
Now you have to swap your because it's
The
in the
screens.
yeah, it's in presenter mode.
Okay.
So if you go it's somewhere at the top of the Zoom, there's a button where you can swap your yeah, there you go.
Okay. Oh, very good. I didn't know that. Learn something new every day. Thank you very much.
You're welcome.
All right. My name is Tracy Cross. I am a provider and hospital facility advocate for Delaware. I am also a digital specialist um, working for United Healthcare. Today, we are going to go over the service model and the availability of digital solutions for United Healthcare. We're always looking to make the portal work better for you, provide enhancements in order to help you work faster, easier, and smarter. I'm sure you guys have noticed that United Healthcare, along with other companies, are moving towards a digital self service option through the portal. So we'll discuss some of those availabilities. On the provider portal, when it comes to the self-service options and the service model, United Healthcare has more than 40 tools on the portal that allow you to take action on claims and get the answers that you need quickly without having to sit on hold in a call center. It's available 24/7 and there's no cost to you, all without having to pick up the phone. As we continue our upgrade for digital solutions, we are introducing improved systems to help you do business with us. The portal allows you to quickly get the answers that you need so you can save valuable time and get better documentation and visibility. I'm sure most of you already have a One Health ID number. That is what is needed in order to log on to the portal. Under provider services, if you need to speak with someone, you can contact these numbers here. This presentation will be given to Christy or has been given to Christy for distribution. So there's a lot of slides. Don't worry about trying to write down all the numbers. You'll get a copy of the presentation if you so desire. Provider services has web support, prior authorizations if you're not able to do it online or you're having trouble doing it online. Provider services for the individual exchange plans, the Opt and Pay Help Desk. You can get copies of the cards. The phone number is also available on the back of the card. Sometimes it varies by plan. If you're still not satisfied with the information that you're seeing on the portal and you have additional questions or need additional information, the information here, the link here, will provide you with a list of contacts by state. For the provider portal, I'm sure you guys have noticed that advocates are
pushing the provider solution, I'm sorry, the digital solutions. And we are now taking calls for the call center in an attempt to educate the callers on the information that's available online, and familiarize everybody with how much information is out there for you. So when we look at the information, you can explore the various digital solutions. The most common one everybody knows about, I'm sure, is the electronic data interchange from the center tile. That is, industry standard, doesn't have, don't need to go too much into that unless you have specific questions. But the newest digital solution that we have done outreach on lately is the API, which is the Application Programming Interface. It is similar to EDI, but you get more information. Um, it is considered a fully electronic solution. It can be used for single or batch transactions, but it's really useful for larger health systems and providers because the large volume it can handle. It does require some IT involvement to get it set up, but it is very common and can be used to instantly pull up information and automate data feeds. It can replace existing digital solutions or it can enhance existing digital solutions based on what you need and what resources you have. The other option is the provider portal. It's our self-service tool, provides as much information as we can give.
I think you cut out.
Transactions.
You
Did
cut
I?
out. You cut out for like a
Can you hear
second.
me now?
Yes.
Hello?
Yes, I can hear you now.
Are you able to hear me now?
Yes, though I think we may keep losing you. Can you hear me?
Hello?
Oh, Tracy? Or is it Tracy?
Can you not hear me?
Yes. I
You
can
can
hear you
hear?
now. Can you hear us?
Okay.
Okay.
I can, yeah. Okay. All right. All right, so the provider portal, you can check eligibility, benefit information. We're continuing to upgrade those digital services. We are available again 24/7 anytime, and it has additional information. You can access the document library, claims information. You can submit a corrected claim. You can submit a new claim. You can submit reconsiderations and appeals online, plus more. So if you go to the portal, uhcprovider.com, you would hit sign in, and you'll get this screen, and you would select type in your One Healthcare ID and your password. When you get into the system, you can reach the Track It page, the Track It section, which is basically a daily to-do list for your United Healthcare claim related tasks. You can see any action that's been taken. You can take action on those that require your review. You can do it all in one place. So if you need to upload a document, you can do it here. If we're missing some information to process the claim, Track It will tell you. There's no need to pick up the phone or wait for the mail. You can complete many of those actions without leaving the portal, the tool. It's faster, saves clicks, and reduces unnecessary searches. For the portal here from the landing page, you can take action. You would select the Action Required tab, and it calls your attention to items across multiple applications that require your attention. You can select an item from the main screen or go to the Track It in the upper right-hand corner. All right, and you can select whichever action you would like to take. We can look at pending claims just as an example. So in this example, you see that there's 8 that require action. You would select that, and it'll take you to that description page. So from within Track It, you can review those notes and immediately take the action that's required. So in this example here, you can see the link that says action required and the note that says that we need the treatment records that have been requested. you can add that from this page. In this case, adding those treatment records would be far faster than trying to either create a new pick ticket or mail the records in. Eligibility and benefits. This is one of the most common reasons we are getting calls to the call center. The information is available on the portal. You just need to click on the eligibility link. You can check the eligibility, excuse me. You can view it, download it, you can save the card, you can find their cost share, determine their network status and tier status, view the coverage details and the limitations. You can view detailed benefit information, previous member benefit plan information, preventative care opportunities for some plans, not all plans. You can also see if referrals are required, if notification or prior authorization is required. You can see the therapy accumulator information. In addition to that, going back to the home page, you can select the eligibility tab and search on a specific patient. There are multiple ways to search. You can search by the name, the ID number, the policy number, etc. You can review the policy details once you have selected the patient. You can see other plan members as well. If you needed to look at, say, a family and had twins or, additional children, you're seeing multiple people on the same day. You can go to the ID card and pull up a copy of the ID card, front and back, and it will show you the information that's available there. And it will be the most updated version of the card. Additionally, you can see quickly what has been satisfied for the patient and the family's deductible and out-of-pocket maximum. You can review copay, coinsurance amounts for popular services. You can check specific benefits. So in this instance, if you wanted to check on, say, hospital service benefits, you would click on the hospital service, and it'll bring a drop-down list of many of the hospital services available. You just click on the link. All of the blue characters are links. That's what's covered in the policy. You also see the coinsurance, the deductible, whether or not it applies to the deductible. If it's covered in the policy, you can print or you can download it. So you can save it as a PDF and save that for your records. For claims, you can look up the claim status and any action that needs to be taken on a claim. Gives you the most up-to-date claim status and payment information with the ability to submit a claim reconsideration request or an appeal decision all in one easy-to-use tool without having to call, mail, or fax anything. You can view the claim information for multiple United Healthcare plans. You can access letters, remittance advice documents, and reimbursement policies. You can submit additional information requested on pending claims. You can flag claims for future viewing. You can submit corrected claims or claim reconsideration requests. And you can receive instant printable confirmation of your submission. That to me is the most, attractive point, is that you get a tracking number in addition to being able to do all of this instantly and 24/7. Regardless of how the claim actually gets to us, you can check the status on the claims and payments tab from the portal homepage. You can enter your search parameters and do a search. You can select the appropriate claim, whichever one you're looking for. It'll bring up the options. And then you can review the details. So you can see when it was finalized, when it was received, if it was paid, what the status is, how much was paid, what codes, and any patient liability. You can see remark codes if there are anything on a claim that affects how it was paid. There are also line level details available if you select that view. Excuse me. The payment information and any available letters and remittance documents are available to print and save as well. At the bottom, under Act on a Claim, if appropriate, you can submit a corrected claim or add attachments, or you can submit a reconsideration or an appeal, all online without having to call, mail, or fax. For referrals, you can check and see if there are requirements for referral. You can see if there's a existing referral, if you need to submit a new request. You can search for the patient in the referral tab, check the status on a referral, or you can copy an existing referral, or you can submit a new referral. You can then do the same thing for prior authorizations. So if you would like to create an authorization or copy an authorization, you can also inquire on if authorization is needed for specific codes using the check by code and check by member features. Make sure you do it by the member. Don't just go in and look at, say, commercial, because it may vary by the employer group, because they might have different benefit plan requirements. So always go in, if you're going to check requirements for authorization notification, always go in by the member specific. You can do the same thing in this screen as well, just to check and see if prior authorization is required. This is a view where you can click on check by code or check by member. Again, always check by member. When you go into check by member, it will give you the option to type in the code to see if the prior authorization is required. Could be for various different types of services. And we do have Evercore and I think I can't remember the name of it. There's another company too that helps with specific types of prior authorization requests. After select appropriate patient, you would enter the service details and the ordering physician details, ordering provider details. You can then add the diagnosis codes and the procedure codes. And you can request an expedited review online. The standard response time is 10 business days, but the maximum expedited review time is 72 hours. This is just another view. You can go in and check the status on your requests. And you can review those details on what was approved, or if it wasn't approved, and what the reason was. You can also review existing attachments and even add new ones. Moving to the document library, you can view and print your documents. You can assign, manage, and comment on the documents using Teams View for your own internal use. You can download letters and provide a remittance advice for up to 24 months. You can search any 90-day period for up to 2 years. You can customize your own view, manage multiple documents at once, and you can see your most recently added documents as well. You can also choose whether to mark letters and documents as read or unread. There are also additional tools here that may help you, and under documents and reporting. The document library holds various letters for 24 months. You can browse the different categories and just simply open the file. You can save it, you can print it. There's also a quick search, which automatically searches the last 90-day period using a single criteria. You can, If that doesn't work, you can also use the advanced search to go back 2 years with multiple criteria within 90-day batches. You can update and attest to your care provider demographic data. This information is available online, so it is the My Practice Profile tool. Lets you view, update, and attest to the care provider demographic information that United Healthcare members see from your organization. You can use the tool to make demographic changes just one time in one place and get those updates into our system more quickly. My Practice Profile is under Practice Management. Lets you view, update, and attest to your demographic information. We have multiple resources to help you regarding all of these and more. From our homepage, you can go to uhcprovider.com, the homepage, click on resources. It'll bring a drop-down menu and you can make a selection based on what it is you're requesting or looking for. You can select education and training. And you'll have self-paced training. There is also instructor-led training. Just depends on what it is you would like to learn more about. You can expand the United Healthcare Provider Portal tools to see what's available. Instructor-led learning events are available. If you click on that page, we offer training for several of the portal features. You can register for any or all of the events, whatever it is that you would like to learn more about. You would simply click on the register for the live event. You can expand the United Healthcare Provider Portal tools in order to see everything that is available when it comes to training. So for instance, if you wanted to learn more about the claims follow-up, you have an interactive guide, instructions on how to submit electronic reconsideration requests, the Track It interactive guide, claim submission instructions, the document library instructions. All this information is available to you at any time of the day or night. Under practice management, there's additional information about My Practice Profile, Onboard Pro, how to create and manage, users if you're the administrator for your tax ID number for the portal. And when you go to the quick start guides, they have those available for claims search, claims reconsideration, fee schedule lookup, any of those that you would need. There's also additional information about connectivity when it comes to EDI and API. At the bottom of this page, there is information about the EDI and API transactions, both variations of computers talking to our computers, making the transaction process much more efficient all the way around. Additionally, under Contact Us, there is more information. If you scroll down, you can see technical support for the provider portal. So if you're having issues, you can use that, or you can make a phone call, or you can use the chat function. Excuse me. When you're signed into the portal, the dialog bubble there in the lower right-hand corner indicates the chat. So if you still have open issues or concerns, if you're not satisfied with the information that you're seeing or you need additional information, you can always use the chat feature. So you can kind of multitask while you're not tied to a phone, making a phone call, and the chat should be able to assist you further. And that's pretty much all I have. Are there any questions?
Thank you. Thank you so much. We did receive a few questions that came into the chat here. Let's see here. Okay. So in the web portal, is there a way to see the full information about a patient, namely to confirm that the information is accurate, such as their date of birth?
Yes, you'll see what we have listed in our system for the date of birth. So there occasionally, it's very rarely, the state might have, they might be a day off, or they might have a typo or something like that, or we do, whichever party, but they might have something slightly different. And so, that would require the member to contact United Healthcare and straighten that out. But the majority of the time, the information that we have, we either get it from the state or from the member paperwork. So what we have available in our system is what's available in the portal.
Okay. The next question is, why does United Healthcare request documents frequently? We are contracted and it's a job for us to provide United Healthcare with these documents. E&M coding is being disputed when the office visit supports the level of service. Um, is this something that I can get you connected with this person directly? Can they reach out to you?
Yeah, just you can either send them my email, or you can forward the contact information, my contact information to them.
Okay, great. The next question is, will we need to request a copy? Oh no, no. Okay. So as far as the presentations go, I will be sending out copies shortly after the presentation. If not today, definitely by tomorrow, as long as I have all of those approved copies to be sent out by today. The next question is for the United Healthcare Complete Care HMO and POS. Online, it shows that we are out of network. When we call to verify the reps advise us that our group MPI is in network, but the individual providers MPI are considered out of network.
You would probably need to see, that doesn't make any sense. What kind of practice is it?
I'm not sure, but I can also share with them your contact information and I think that may be best as well in that case.
Yeah, and if not me, then their contractor who
Okay.
can explain that.
Okay. Are there any other questions? Oh, she says they're an orthopedic.
Okay. Yeah, that I don't understand that unless there's like a lot of therapists or something. But I would have to look at the actual contractor, have the contractor do it.
Okay. Well, looks like that's all of the questions. I want to thank you I want to thank you for today's presentation. Um, see, what we're gonna do is we're gonna take a short break. We're a little bit ahead schedule. Our next presenter is Delaware Medicaid. And so we're just gonna take a couple minutes break and we'll be back in about 5 minutes.
Thank you.
You're welcome. Hi, I'm back. Is Nikki, are you here?
Good morning. I am here.
Great. Would you be able to do your presentation for us
Sure.
now?
Sure. Give me one moment. Let me just pull up the
Okay.
presentation.
Okay, I'm gonna end my screen. See here. Okay. So Mary Health Caritas has presented, Cigna has presented, United Healthcare. Delaware Medicaid should be next, and right now we're going to have Nikki Cleary with Delaware First Health present.
All right. Give me one moment.
Okay.
I'm going to share my screen. All right. Can you see my screen?
Yes, I can see it.
Just minimize this. Sorry for the scrolling. All right. I am ready. Good morning, everybody. I am going to leave my camera off in an attempt to reduce the technical difficulties. Again, good morning, everybody. My name is Nikki Cleary. I am the Director of Provider Engagement for Delaware First Health. Thank you for joining the 2025 MSD Pair Workshop. A copy of this presentation will be sent to participants after the workshop. Here is our agenda for this morning. As you can see, we have a lot of topics to cover. We will discuss plan updates, RX effects, HEDIS and provider incentives, EPSDT, workforce development, some billing reminders, provider resources, and training. Plan updates. Delaware First Health has earned the Health Equity Accreditation and the Long-Term Services and Support Distinction from the National Committee for Quality Assurance, also known as NCQA. This honor reinforces Delaware First Health's commitment to providing accessible, high-quality care to our members. On our website, we now have a quarterly provider newsletter. The first volume of our newsletter was published in July of 2024. And the volume 2 publication was published in October of 2024. Please visit our website to take a look at our provider newsletters. They are packed with helpful information. We have a What's New corner. We have a Claims corner. We talk about upcoming events, provider training and education. We talk about provider incentives. There's a lot of information in these newsletters. Please visit our website to take a look at our newsletter. Once you get the presentation, the hyperlink is embedded in the slide that'll take you directly to our provider newsletter. Involve Dental, doing business as Centene Dental. They administer both our adult and our pediatric dental benefits for Delaware First Health members. As of January 1st, 2025, the pediatric dental benefit has transitioned to the managed care organizations. There are no co-payments for dental services for children. There's no need for that extended or emergency benefit that we used to have or that process. And if you have any current prior authorizations, they will be honored. For more information, you can visit our website or visit the Centene Dental website directly. Avail of the essentials. As of October 21st, 2024, Delaware First Health has a new secure provider portal. It's Avail of the Essentials. It is currently live in addition to our legacy provider portal. You can currently use both portals until we have fully transitioned 100% to Availity. We are having a phased approach. Currently, we are in phase 1. In phase 1, you can verify member eligibility and benefits. You can submit claims, you can check the claim status, and you can submit authorizations. For more information, if you're already signed up for Availity Essentials, you can log into your Availity Essentials account. If you are not registered for Availity Essentials, you can click on the link in the presentation, register and get started with Availity Essentials. In addition to our Phase 1 portal functionality, we also have live our risk condition validation, known as RCV, and our clinical quality validation, known as CQV. Both of these tools are used for closing risk gaps and care gaps. RCV is used to close risk gaps, and CQV is used to close care gaps. You can also use the RCV app for our continuity of care program. Both apps are quick and easy alternatives to the current submission, such as faxing or mailing in that information. If you are already registered for Availity Essentials, but you do not see the RCV or CQV apps, please contact your Availity administrator and ask them to assign you to the clinical, risk, and quality role. That will enable you to see both those applications. Next steps. I'm not going to go over this whole slide, but it gives you the steps if you are not signed up for Availity, if you're not sure, if you're the administrator, if you're not the administrator, it gives you the steps as to what you need to do. What I do want to note here is that Availity has a learning center. That learning center has provider resources and training to help you learn and navigate Availity Essentials. Also, I previously mentioned RCV and CQV. There is a demo of the RCV app, and there is a demo of the CQV app once you sign into Availity Essentials. And if you have any questions on utilizing or navigating in Availity, you can contact Availity's client services. The number is provided for you on the slide. Are there any questions regarding Availity Essentials or any of our plan updates?
No questions so far.
Thank you, Christy. RX Effect. RX Effect is a platform that streamlines prescription management and it improves our members' care. RX Effect simplifies the prescribing process, enhances medication tracking, and ensures better patient outcomes. Some of the key features of RX Effect include real-time prescription tracking, medication alerts, and it has a patient communication tool where providers can communicate with their patient about prescription updates and medication adherence. Also, RX Effect seamlessly integrates with existing EHR systems. To get started with RX Effect, please contact your dedicated provider account manager using the link that is in the presentation. That hyperlink will take you to our website where it lists all of our dedicated provider engagement account managers' contact information. We are encouraging all of our providers to use RX Effect to support med adherence in the areas of diabetes, hypertension, and cholesterol. There is no cost to use the tool. Currently, RX Effect is available for our Ambetter or our Marketplace and our WellCare, which is our Medicare lines of business. RX Effects will be coming soon to our Medicaid line of business. If you have a WellCare member, providers can earn up to $300 by utilizing this tool. We will be having an RX Effect provider forum in February of 2025, so stay tuned for more information. Are there any questions regarding RX Effect? No?
Nope, no questions.
Thank you. HEDIS and provider incentives. This is just an update regarding HEDIS hybrid season. Our HEDIS hybrid season does begin next month and it runs through the end of April. We have partnered with a vendor, Datafied, to conduct our chart chases. Datafied will have an assigned contact person for each provider. That assigned person will contact their assigned provider offices and request medical records. So if you do get a call or outreach from Datafied on behalf of Delaware First Health, we ask if you could please provide them with the medical records in a timely manner. If Datafied is unable to obtain the medical records from the provider office, the Delaware First Health staff will then outreach to that provider in an attempt to obtain the medical records. And then the Delaware First Health staff will also assist with those chart reviews. And if we need to log into your EMR, the Delaware First Health staff will assist with that process. Provider incentives. These are the provider incentives for each of our lines of business for our PCPs. I'm not going to read them all. We do have some great incentives for things that our members need to do, such as well child visits, also the adult preventative visits. There is a $50 provider incentive for that adults access to preventative or ambulatory health services. We also have a $30 incentive for those child and adolescent well care visits. You know, I'm not going to go over all of them. Please review this at your leisure just to take a look at your the provider incentives that you could be receiving. And if you have any questions, definitely reach out to your assigned provider engagement account manager. In addition to the provider incentives that were listed in the previous slide, we do have a pay for performance program and a partnership for quality program. The P4P program is for our Medicaid and our Ambetter, which is our marketplace line of business. And the partnership for quality is for our Medicare lines of business, which is our WellCare brand. Both programs pay out 3 times a year, and our P4Q has a final true-up payment. For both programs, our P4P and our P4Q, there are monthly performance reports and care gap reports that are available in our secure portal. Are there any questions regarding our provider incentives? I'll take silence.
Yes,
Sure.
it does seem like a question came in. How do we access the incentives? Was the question, though. It looks like somebody already answered the question by going to the secure provider portal. They can reach out to the provider engagement for further details. Is that?
Yes, that is correct.
Okay.
Thank you. Early and periodic screening, diagnostic, and treatment, known as EPSDT. Delaware First Health, we want to ensure that all our pediatric members are receiving all the medically necessary services that are covered under the EPSDT program. We have a team of dedicated EPSDT coordinators who conduct outreach to members that have open care gaps, such as those missed well child visits, missed screenings. The team will attempt to contact them, and our team may also contact your office regarding those patients that are assigned to your panel. We want to partner with your office to provide EPSDT materials and content, postcards that you can send your members, quick reference guides, and to discuss your members that have open care gaps. On our website, we do have a EPSDT member outreach form that is available. So if you're struggling or having a hard time getting a hold of those members, those Delaware First Health members that have open care gaps, that have not had an annual well visit, we are here to assist you. Please download the member outreach form from our website, complete it, and email it back to our department mailbox, which is listed on the form. If you have any questions regarding EPSDT, please contact Nikki Alexander. She is our dedicated EPSDT coordinator. Her contact information is on the slide. In addition to her email address that's on the slide, we also have a department email box that is listed on that outreach form. If you have any questions, you can email Nikki directly, or you can send an email to our EPSDT email, epsdt@delawarefirsthealth.com. Member rewards that support EPSDT. Delaware First Health, we reward our members by focusing on their health. Members can earn rewards by completing healthy habits such as annual wellness exams and screenings. Listed here are some of the rewards that support EPSDT. For example, Just for the member going out to our website and registering for our portal, they will get a $10 reward on their My Health Pay Rewards card. If they have an infant from age 0 to 15 months, once they complete 6 well visits, they will receive a one-time reward of $100. We also have a $15 flu vaccination reward for ages 6 months and up, and that reward is available once per year. Members can learn more about our My Health Pays reward by visiting our website at delawarefirsthealth.com. Are there any questions regarding EPSDT or our member rewards program?
Nope, no questions, Keeman.
Thank you, Christy. Workforce development. The MCOs in Delaware are tasked with assisting providers in workforce development. I know we can't solve for it during our short period here, but we're here and we want to know how can we help you with workforce development. We want to know what challenges that are you facing with hiring, recruiting, and retaining healthcare workers. What strategies do you have to address these barriers and enhance the workforce, enhance workforce development? Also, we want to know, do you have any current workforce initiatives? We would love to hear from you. Please email us at DE_providerengagement@delawarefirsthealth.com with all your workforce development concerns, inquiries, or any initiatives that you do have. Again, this presentation will be provided at the end of the workshop so that you have our email address. Are there any questions regarding workforce development?
No questions.
Thank you, Christy. Billing reminders. These are just some friendly reminders. We have been seeing a lot of denials recently regarding missing taxonomy. This is just a reminder that claims submitted without the billing, rendering, or attending taxonomy will deny or reject. As listed in the DMMA billing guide and the Delaware First Health Billing Manual, all claims without the billing, rendering, or attending taxonomy will deny or reject it. So what you're seeing now, if you're not billing with that taxonomy, is that your claim is being denied. We will be moving to rejecting those claims up front at the clearinghouse level. So in order to avoid those denials right now and possibly avoid those rejections at the clearinghouse level, we ask that you submit with the taxonomy for the billing, rendering, and attending provider. If you have any questions, you can definitely always reach out to our provider services team or your assigned provider engagement account manager. I don't want to beat a dead horse with this. I know both of the other MCOs talked about this during their presentations. Balance billing the member. We reimburse services that are medically necessary and covered through the Medicaid program. Providers are not allowed to balance bill members for covered services. Claims dispute process. If you disagree with how a claim was processed or the expected payment, as outlined in our provider manual, you have the right to file a reconsideration. For claims that do not require any correction or change to the original bill claim. Also, again, if the claim is paid at less than what you expected, you have a right to file a claims reconsideration. Your provider engagement account manager is here to assist you, but you must follow the process that is outlined in our provider manual if you disagree with how the claim was paid or a denial. Please note that a request for reconsideration must happen before you file a claims appeal. Here is our claims dispute process. I'm not going to go over it in its entirety. Please review this once you get the presentation. Again, if you disagree with how a claim was finalized, if you disagree with the denial, if you disagree with the payment, your first step is not going to your provider engagement account manager. Your first step would be to file a reconsideration. Reconsiderations can be filed in our legacy portal at delawarefirsthealth.com/providers/login. The reconsideration request must include the claim number and, if applicable, the authorization number and supporting documentation. If you're submitting a reconsideration, for example, for an administrative denial such as no auth, we don't need the medical records. What we need to know as far as supporting documentation is the authorization number, that you obtained an authorization number for those services that you are billing. All requests for reconsideration must be submitted within 90 calendar days from the EOP or from the provider remittance. In addition to submitting a reconsideration in our provider portal, you can also mail in reconsiderations to the address listed on the slide. If you disagree with the outcome of the claims reconsideration, your next step is not contacting your provider engagement account manager. Your next step would be to submit an appeal. You have 120 days from the date of service or no later than 60 calendar days from that reconsideration decision to submit your provider claim appeal. The provider appeal must include the provider appeal form. The provider appeal form is on our website under manuals, forms, and resources. In addition to the provider appeal form, you must include a copy of the claim in question and a copy of the EOP and the supporting documentation. That information can be mailed to the address you see on the slide, or provider appeals can be faxed to 888-865-6531. Are there any questions regarding the claims dispute process?
Looks like we did have a question that came in, and the question is, do you know if hemoglobin checks in the office for a pediatric office is now totally non-CLIA, or do we need to use a different code? We keep getting a CLIA denial for that test.
Yeah, that's a good question. I'll have to take that as a takeaway. The person that has that question, if you can drop your contact information in the chat, and someone on my team will gather that information and have your dedicated provider engagement administrator reach out to you for assistance.
Thank you so much. That was the only one that came in.
Thank you, Christy. Next up is provider resources and training. Delaware First Health, we provide tools and support delivering the best quality of care to our members. We have a ton of provider resources on our website at delawarefirsthealth.com under the provider section. Also, as I previously mentioned, the dispute process, the billing requirements. On our website, we have our provider manual, which is under that same provider section, but it's under resources, forms, and manuals. Some of the forms that we have listed on our website are listed on the slide. We have a PCP change form. So for those PCPs, if the members come to your office and you are not listed as their PCP, you can access the PCP change form from our website. And we will go ahead and make the change for that member in our system and issue a new ID card to that member. We also have a provider data update section on our form where you can submit provider data updates directly on our website. We have a provider feedback form. We want to hear from you. We want to know how we're doing. We want to know if we're doing well, if we're not doing well. We want to know what you like, what you don't like about Delaware First Health. Please access our provider feedback form on our website and provide us with some feedback. One of the newest forms that we just have added to our website as of this month is our provider PCP annual attestation form. This form is to be completed by all PCPs on an annual basis. Your dedicated provider engagement account manager will be reviewing this form with you to ensure that it is completed on an annual basis. That form is attesting that you do not have more than 2,500 patients assigned to your panel. That's not just for Delaware First Health or the Medicaid MCOs. That's across all payers, including commercial, marketplace, and Medicare. Also, in that attestation, you will be attesting that you did complete a cultural humility course on an annual basis within the past 12 months. For more information, you can check out the form on our website, on any of those forms, or reach out to your dedicated provider engagement administrator. Our provider engagement team is dedicated to improving our partnership with our providers. We provide ongoing education and training. On our website, under provider training and education, you will see a full listing of all the available provider training and education. We have behavioral health training. We have resources for cultural competency training, LTSS training. We offer a monthly new provider orientation. We offer a monthly secure provider portal webinar. So please visit our website for a full listing of those available trainings. Embedded in the slide is our training schedule for Q1. It lists all of the training that is available from January to March of this year. That information was also recently emailed to the email addresses that we have on file. If you have not received that training schedule via your email, please reach out to us at our department email. And if somebody from my team could drop that department email in the chat, I would appreciate it. Clinical documentation improvement webinars. In addition to the training that I just mentioned, we also have training on clinical documentation improvement. This month, we are offering training on risk adjustment, coding, and documentation. Please join us for a discussion that includes an overview of our risk adjustment program and how it impacts you, tips on how to improve documentation and coding, and tips to stay compliant with regulatory requirements. These webinars are open to all providers, physicians, non-physicians, coders, billers, and administrative staff. This concludes my presentation. Are there any questions?
Thank you so much for your presentation. A lot of great information. I don't see any other additional questions that came through the chat since the last one, but
Thank you very much.
allow a moment just in case. In the meantime, I believe you did say that your presentation will be made available for everyone, correct?
Yes, yes, and I'll send
Okay.
you the finalized copy.
Oh, great. Okay, that'd be great. Okay.
No questions?
No questions. Well, thank you so much for your presentation again. It was great.
Thank you.
Okay, so our next presenter is Delaware Medicaid, and we have Andrew Wilson, the Medicaid Director. Hi, Andrew, are you there?
I am. I even come on camera.
Nice, good to see you. It's been a while.
Hi, although I think I'm talking to myself on the camera, but that's all right. Yeah, it's good to see everyone, sort of. No, I'm glad to be here. I have some slides. Should I just share my screen here, Christy? Is that the easiest way?
Yes, that is the easiest way.
All right, we can do that. Oh, there you go. I didn't mean to pressure you to come on. Hi, Christy. It's good to see you, though. So here, let me well, here before you just have to look at slides for a minute, let me just talk at you for a second. So, hi, I'm Drew. I'm the Medicaid Director here in Delaware. I've been in this position just a little over a year now, I'm coming in a little lighthearted because it's a little like homecoming. So it's great to see Christy and Lynn. I used to work at the Medical Society, and so I actually started my Delaware career doing policy and lobbying for the physicians of Delaware. Directly at the Medical Society for about 5 years. And then I joined Morris James as a practicing attorney and brought the Medical Society with me. So I worked with the society itself, still doing kind of my old job, and then also worked with a lot of small practices and physicians. And so I definitely have a deep empathy and understanding of all the different things that practices have to deal with on the ground. I mean, your small businesses, your employers. I mean, you touch all these sections of law and policy, and that, you know, the day-to-day billing and things that we're talking about today is really just such a small part of everything that you need to do. So I certainly feel for you, and I am glad to be back. And after I left Morris James, I actually went up. I went to CMS, so I went to the Centers for Medicare and Medicaid Services for about 4 years. I joined it for the pandemic. I didn't know I was joining it for the pandemic, but that's about when I was there. To give you an idea of when I joined, it was, hey, so glad you're here. We'll ship you a laptop and we'll see you in 2 weeks. And then it was 3 years later before we saw anybody, you know? So it's a very interesting time to jump into the federal side of things. But it did give me a great viewpoint of Medicaid programs across the country. And a respect for our federal partners. And we'll talk about that a little bit more today. And then, as I said, been back about a year, and am so grateful for the physicians of Delaware, the practices of Delaware, because our Medicaid program is here to help make sure that our beneficiaries, about a quarter of Delaware, has access to quality care, and we couldn't do that without you. So thank you for doing that, and thank you for being here and learning how to engage with the Medicaid program. I'm so glad that the MCOs are here and we're able to speak more of the nuts and bolts. Lyndon actually texted me the other day because I asked her and I asked Christy as well, kind of what do you want me to cover? And it's very nitty gritty stuff. And I was like, boy, I don't know. I'm going to be very disappointing to you. And I'm sorry, Lynn, like even today. So my slide deck is going to be like, which one of these things is not like the other one? Because we're actually going to take a step back. Because if the MCOs talk, they told you all the stuff you need to know about kind of on the ground billing, because we are a managed care state. And so they're the ones that are very provider facing. They're the ones that you're submitting claims to. And so all the sort of nitty gritty day to day, they're the ones that you're probably going to be working with. We have a very small fee for service program where the state is the payer, but it's really for about 30 days or less before we can get a beneficiary who's enrolled with us into an MCO. And so our fee for service program is very small. And so with that here, let me start sharing my screen here. And we can hop into, does it share automatically or do I have to? Boop, boop, boop. It's so hard because I can't see any of you either. I also can't see comments when they pop in when I go and do this and share my screen. So Christy, if there's anything that pops in, just let me know and I can shut up for a minute and answer some questions along the way.
Yeah,
Feel free to interrupt me anytime.
I'll be running the chat for you, and we can hold those to the end.
Okay.
Kind of answer them all at once.
Okay. So we're, like I said, sorry, Lynn, it's not going to be very nuts and bolts. This is going to be definitely which one of these presentations is not like the other one today. But I do think it's important. And one of the things that I learned, I spent so much time working with physicians and practices, but I realized until I sort of got into this position that a lot of the stuff that I thought I knew, I never really had a good grasp of the big picture of how Medicaid works. So I wanted to just a little bit of a level set. This is a little bit of a smaller group, so you can give me some blunt feedback on what makes sense and what doesn't make sense. I'll be sharing some fairly densely worded slides. It's not my expectation that you read them. I'm glad to share them. We'll just sort of talk high level as we go through there. And then overall, our program runs on an annual basis. So we're just getting into a new year here for 2025. And I'm glad to talk about some of the bigger things that we're doing, the bigger things that we're changing, and talk a little bit about what we're sort of seeing on the horizon for 2026. And let me also say that we're here to try to really listen to mostly beneficiaries, but that doesn't mean that we don't have special ears on for hearing from practices. Because if you're hitting friction points and you're having problems, we need to know that, we want to hear that, and we want to respond and help make your lives easier so that you can care for the people of Delaware. So I want you to know that you can always pick up the phone and call Medicaid. We want to hear about how things are going on the ground. If I don't say it along the way, somebody remind me at the end that I want to talk a little bit about our advisory committee as well. So if I don't say that, I'll try to remember when the appropriate slide comes up, but somebody shout at me at the end. So I think one of the things that's most important to remember about Medicaid is that even though we talk about the state level and what the state's doing, it's really dually administered, which means that pretty much everything that we do at the state level, we decide to cover something, we decide to pay more for something, we have to take it up to CMS at the end of the day. Because there's about $1 billion of state funds in Medicaid. It's by far the biggest part of our $6 billion state budget. But that $1 billion of state funds brings in $2.2 billion of federal funds. And so the federal government has a huge interest and a lot of say in how things go. And so we're going to talk a little bit about the different pieces, but it's very important to know that a lot of times practices, beneficiaries will come up to me and say like, hey, why don't you do blah, blah, blah. And it's like, well, you can do pretty much anything you want to do with state dollars, but the power of using the Medicaid program is that it brings down all this federal support to be able to expand services and stretch state dollars as far as possible. And so that's really the key. And so we're always thinking, well, what can we do with our federal partner? It's a huge, huge, huge piece of what we do. The other important thing to know is that it's an entitlement program. So we're not an insurance company. We use insurance companies. We contract with them. You heard them today. And we're also not like a block grant, although that's being debated right now. But for the moment, we're an entitlement program, which means that we are very responsive to how things are going in the universe around us. And so, unemployment goes up, people start losing jobs, Medicaid gets bigger, and we can't say, no, you can't come on because we don't have the money. It's an entitlement program. We will have to find the money to figure out how to pay for them. And so thinking about our population, thinking about its needs, is always incredibly important. And it's always a little bit of a moving target because throughout the year, different things happen. So, that's why the pandemic was such a big deal for all of us, but especially for the Medicaid program, because it was adding a lot of variability into an entitlement program of we don't know what services are going to be like. We don't know what the population is going to look like. And uncertainty is terrifying for everybody, but especially if you're the legislature who's trying to create a budget. Because these are real state dollars that have to go in. Like while it does pull down federal funds, it's real dollars. We have to decide: do we put a roof on a school or do we put money into Medicaid? So real decisions get made with real dollars at the end of the day. But I will say again that investing in Medicaid is almost always a good idea because it does stretch federal state funds so far. And even like positions like myself, I only cost half of what I look like I cost. The other half is actually picked up by the federal government. And so, investing in it from a workforce standpoint makes sense as well. And then lastly, one of the big things that we were always working for when I was at the Medical Society was universal coverage. And so one of the other things that Medicaid is really good at is we are able to sort of fill gaps in states. And that's where, it's actually it's on the very last slide, but the unofficial motto of Medicaid is if you've seen one Medicaid program, you've seen one Medicaid program, because Medicaid states will use it to sort of say, like, we have population here, we have services here that we don't have sort of either Medicare or commercial coverage for. We need to fill the gaps. How can we use Medicaid to expand into these little crevices? And so that's this is sort of the most informal slide I have, but really Medicaid is trying to figure out how do we get to that goal of universal coverage? How does it fit in? And it's led to some interesting places over time because as an example, we are, sorry, I'm just flipping through my notes. Oh, long-term care. We are the primary payer for long-term care, but that wasn't ever really the vision for Medicaid. But because of the failure of these first three jars, long-term care insurance has effectively collapsed. Medicare doesn't pay for it beyond 100 days. So Medicaid, as the safety net, has become the primary care payer of long-term care. It's not really what we're supposed to do, I think, from like a big policy perspective, but that's the way it is. And because there has been failure in those other buckets, we're here to catch it. And so, it takes up a lot of time and effort, but we are glad to provide these services to Delawareans. But that's a way that Medicaid has been used to sort of catch a sort of a larger market failure. And so as we go through the slides here today, you'll see this one a couple times. We're going to sort of start at the top left in the pink. These are the different sort of elements of how Medicaid works. The eligibility, the services. We're a managed care state, so we'll talk a little bit about how we figure out the budget for managed cares, and then very lightly talk about administration because the MCOs are here to sort of talk about their own stuff along the way here. So the who is remarkably important. It always starts with the who. What are we trying to help with? So Medicaid actually turns, I think it's 60 this year. I think it was first passed in 1965. So we're a big 10-year birthday this year in whatever the heck year it is, 2025. And so it's a big year for us. But the original eligibility for Medicaid when it was first signed into law by Lyndon B. Johnson is known as ABD, the age, blind, and disabled. That's the category of persons that were originally eligible. And since then, it has, of course, evolved. And as I said, we have sort of gone through and we've filled cracks over time. And Medicaid has become, I would argue, the most creative and most interesting payment program in the country in terms of what we cover. But of course, the categories do have a financial component to them. And this is probably what most people think of when they think of Medicaid is what's the financial eligibility, because we are the safety net. And so ideally as a state, we hope that people have commercial insurance. We hope that people are in jobs. People age out of jobs into Medicare. And so we're supposed to be here to sort of catch that. And so we are able to have a little bit of say in terms of the financial eligibility. And so in that middle column there, you can see there's some flexibility for states to figure out exactly in each of those categories, what's the financial range of eligibility. And so, for instance, some states for their CHIP program, for the children program, go up to multiple 100% of FPL. Delaware, we're about 200. So, but that's because we have other programs that have been able to pick these populations up. And so it is designed to give states some flexibility in program design. And as I said, the eligibility groups themselves have grown hugely over time. And so in the lighter blue, these are the things that we have to cover. Again, this is a federal partnership. And so there's a lot of things that we have to bring and make sure in our program. But then we also have people that we can include discretionarily as a state. And Delaware has a very robust Medicaid program. We tend to include everyone we possibly can. And so almost everybody on this slide is in the program, if not all of them. And I will say that we're entering a period now where I'd mentioned we have about a quarter of Delawareans in Medicaid. As some of you may know, we had a public health emergency that changed Medicaid for about 4 years. Our operations, we weren't allowed to remove anybody from the eligibility rolls. We had to keep everybody. And so the program only grew. And so over the course of the pandemic, we reached almost a third of Delawareans. And then since the public health emergency has ended, we've gone through an incredibly time-consuming but very important process known as unwinding to bring us back to regular order, which we've historically been around a quarter of Delaware. We continue to be around a quarter of Delaware. But the tricky part was the people who were coming off the rolls, we really wanted to make sure that they weren't just getting dropped. Because at the end of the day, the core mission of Delaware is to make sure that we are as close to universal coverage as possible. We don't want uninsured people. It doesn't help anybody, especially doesn't help practices whose that you don't want to turn patients away who can't afford care. So we wanted to make sure that we weren't dealing harm while we were returning to regular order. But 2024 was the year that we did successfully do that. And as you can see, we sort of leveled out. We expect over time, this will actually start to tick up again, even though you can see it's sort of been flat for the last several months through either legislative or policy decisions to grow the program, and then also just through the way our state is growing. So we have an aging population. I don't think that's a surprise. It's nationally we have an aging population, but we're feeling it acutely here in Delaware. We are I think we surpassed Florida as the retirement state, if you can believe it. I remember I got phone calls from people coming over the bridge from New Jersey. Apparently there's a big billboard on the New Jersey side that said retire in Delaware. And it's like, oh, great, thanks. Of course, we like to have people in Delaware. We welcome it. But from a program standpoint, it does put pressures on us. As I mentioned, Medicare is obviously the primary payer for our elderly population for 65 plus. But when it comes to long-term care, Medicare really isn't a payer in that space. And so this population in particular has been a big driver of long-term services and supports LTSS. And so that then falls to us. And LTSS is expensive. It's ongoing. It's not an acute episode, as you know. And so we have to be very, very careful about, what is Medicaid and state budgets, what's that going to look like under, over the next, as you can see this chart up to 2050. But, the boomers are here. The boomers are here. We used to actually go to a retreat down in Rehoboth, where all the lobbyists would get together and talk about things to come. And Ed Ratledge from the University of Delaware would come and talk about sort of the future of Delaware. And as early as 15 years ago, he had this chart. And he'd say the gray wave is coming because the demography is destiny, and you could see it happening. And each year the wave got closer. And then I went away to CMS for 4 years, and I came back. And now it's the silver tsunami. It's here. It is crested. It is upon us. And so it's not like we didn't see it coming as a state and a country, but it is here, and it's very real. And so it is, I'd say, a pressing question for us all about what do we do for this population. It also affects access. A lot of the physicians that I still know and love and keep in touch with, retired over the pandemic, either because they were ready or because the pandemic put too much pressure on them. But we're seeing our workforce retire as well because they are also in this population. They're part of the demography. There's not like a separate pool of doctors somewhere that's immortal and away. They're not our elves or anything like that. So we are anxious about, not only do you have a population that needs more services, but the people who can provide those services are now also leaving that side of the equation and joining the, hey, we need services too. So it's really it's tricky. It's tricky. If you have great ideas, I'm here for them. So part 2. So we talked about the who gets to be in the program. Now it's the what. What are the services? So we're kind of in the top right quadrant now. And so I'd say Delaware, again, is very robust. There are mandatory set of federal services that we don't have any discretion in. These are thou shalts. If you are a Medicaid program, thou shalt cover these things. A lot of them are what you'd expect, inpatient, outpatient, vaccines, physician services. But then there's a surprising list of things that are optional. Did you know prescription drugs are optional? We don't have to pay for that. We do, because it'd be silly not to, right? But it's amazing that when people look at this list of, oh, really, like we don't have to have that in the program. Some of them, so again, coming back around to long-term care, like, of course we have to cover home and community-based services. How could you possibly build enough institutions to cover an aging population without HCBS? But in theory, we don't have to cover it. But again, these investments make a lot of sense. And the important thing here is that if they're on these 2 lists, they're eligible for the federal financial participation, which is what I was talking about at the beginning. And so we, again, have a very robust program. We cover pretty much everything that we possibly can and then some. And so at that point, it's, inside of all of these benefits, of course, is the cost of the unit. So, what are we effectively paying out? And so, as I mentioned, well, here, let me get to there in a second. And so how we actually say what we're going to cover, and it includes eligibility as well. The way that we communicate to our federal partner and get approval for that is often through what's called authorities, essentially. And so there are all sorts of different kinds of authorities. You might have heard of a state plan or a SPA, or a state plan amendment. That's sort of the core of the program. And then all of those optional things I was talking about, and anything that you kind of want to do over and above, tend to be through waivers from the federal government. And then in particular, you may or may not have heard of an 1115 waiver before, but the 1115 is where what houses all of the ingenuity of Medicaid. And so 1115s are sort of customized to states' needs and what states feel are important to the population. And effectively, if you can make the case to the federal government that it's going to be budget neutral and is going to be more effective, you can kind of negotiate with them for federal financial participation. So it's a highly political document at the end of the day, because there's so much federal discretion in terms of what goes in here. So our 1115, we are known as what's an omnibus 1115 state. Pretty much all of our services are in our 1115, even though only a subset of them are what we consider innovative. So for instance, we have a diapers and wipes program that's one of the first in the country. I would argue the first in the country, but technically Tennessee got approved about 30 minutes before us. But we asked for it first, so I'm going to say we're first. And we're working on a contingency management program for substance use disorders, not on either of those lists that I showed you before. That lives in our 1115. And so our 1115 was actually just approved last year in 2024, and that starts a 5-year window. But then you might have heard that under the Biden administration, there was a lot of work to expand the role of Medicaid into more social determinants of health, housing, justice, even some states got climate change waivers, palliative care. There are a lot of work to say, well, Medicaid is very important in these spaces as well. So a lot of that work was all through 1115s, because again, the federal government had discretion about what it thinks should be eligible for participation. As you may or may not have heard, we had an election. We have a new administration coming in. And so we just don't know what the appetite is going to be at the federal level for what they consider to be sort of acceptable innovation anymore. They've sort of signaled that they're not on board with broader social determinants of health. But exactly what that means, we don't know until they're in and we get to sort of get a flavor for their leadership. And they'll start to send signals out. They'll produce guidance. because they will want Medicaid to do some things. And so, exactly what that is, justice and substance use disorder tends to be fairly nonpartisan, bipartisan. And so, we'll just see what direction we can go with the program, because there is an appetite to always try to make people's lives better in Delaware, and Medicaid is a big way to do that. But our 1115 is that vehicle to do so. And so all of that stuff, all the who and all the what, all the eligibility, all of our people, everybody who can be in, all the doors, and then all the what, all the services. Traditionally, the state was just the payer. There are still a handful of states out there that are fee for service, but predominantly because healthcare is famously so complicated, and it has gotten to a point where there has to be better management, essentially, of it, that now about 85, maybe even growing now that North Carolina and Oklahoma have expanded into managed care and expanded their managed care programs, probably pushing 90% of Medicaid runs through managed care. And so we are, as I said, a managed care state, and you've already heard from the 3 MCOs. And so the way that we work with the MCOs is that really it's a creature of contract at the end of the day. So we have effectively each year execute a 500-page contract with each of the MCOs that says, here are all the things that we kind of expect you to do. And then here's all the things that we're going to pay you for effectively. And so we have to go through what's called an actuarial exercise. And so actuarial science is the bedrock of Medicaid, both from the state and the federal level. And so effectively what actuaries come in and do is look at data. What is the encounter data? What are the claims data? What is the payment? What is the program? What has the expenses been? What do these different populations, how much does the whole thing cost effectively? And then we contracted out to the MCOs where we asked them to accept the risk of that program, and we pay them per member per month. And so if a person comes in and we feel that they are part of the expansion population, so Magi adults, that 4th one, they get a certain amount of dollars each month for the care of that individual. And so we budget as a state kind of what we think that whole population will look like, but then there's always some variability throughout the year of how many people come in and out of the program. But generally speaking, at that point, with that relationship, the MCOs then take on the risk of, for the individual persons that are enrolled with them, they are then responsible to make them as healthy as possible, make sure they have access to the services that Medicaid has promised. And we then sort of enter an oversight role where we are measuring the quality outcomes, we are measuring access, but by and large, the MCOs then take on the responsibility of the day-to-day for the individual persons and their relationships with you, which is why you sign contracts with MCOs and you don't sign contracts with states at the end of the day. And as I said, we delegate that, again, administration to the MCOs, and we do the oversight. And so I got rid of a bunch of administration slides once I knew the MCOs were going to be here. And so they sort of picture this then feeding into the 3 MCOs presentations. And so with that, Medicaid is never boring. It is constantly moving. There are always changes happening. Either we're changing the size of a door, we're changing the eligibility and trying to let more people through that door to meet a need that we see out there. Or we're saying the people that are through the door and in the program, we need to meet a need that they have. And so this is just a small selection. These are not all the program changes that happened in 2025. Medicaid, as I said, there's been a lot of pressure from the federal government. It's actually the last bullet. They passed a lot of rules, thousands and thousands of pages of rules for Medicaid. How many of those rules survive in the next administration is a TBD. But for the moment, if it's written down and it's passed, we have to strive for implementation and move towards it. So we're doing a lot of that. And then, at the state level, our own legislature, our own governor have priorities, and so long as they can fund something, again, we're not an insurance company. We can't sort of move money around. We're an entitlement program. So if the legislature comes up with the funds to add in a new benefit, we then implement it. And so, for instance, the very beginning of the year, the second bullet is not eligible for federal funds. We had to do it only on state dollars because of the Hyde Amendment. But we launched an abortion benefit where If you have a member who needs access to abortion services, they can now access a Medicaid benefit up to $750. It does not run through the MCOs though, which is one of the things I wanted to talk about today. That is an example, but because it is only state dollars and we can't pull down federal funds, so we don't put it into the MCO contracts. The managed care organizations can help navigate people, but the actual payment of the service is just here in Delaware, and it's just the state paying for it. So that's a nuance, but that's important in case you run across it in your practices. And then I know that I'm not talking to dentists, but I think it's worth mentioning that if you deal with a pediatric population, we're moving our pediatric dental program, or have moved our pediatric dental program into managed care. And so the managed care organizations should be helping and will be helping navigate kids into the dental care that they need. And so, we know as the medical evidence has accumulated over time that dental care is healthcare at the end of the day. And so, we want to take that very seriously and sort of look at it holistically in our population and our kids. And so our managed care organizations are going to help us with that. And then some other sort of bigger ticket items. Delaware's late to the game, but they passed a hospital tax last year, and that's being used to fund potentially new services in Medicaid. And then one of the last acts that Governor Carney had before he left office was he executed an agreement with Nemours to enter into a global budget, which we could spend a whole day on if you want to, but effectively trying to really test the premise that if you can move away from fee-for-service and take the risk on as a organization, that you can spend dollars a little bit more wisely, where you can break out of the CPTs and look at the kid in front of you and say, actually you need, a new rug in your house to help deal with your asthma because you got mold. And that's not a CPT, and so we've got to be able to, or the hope and the premise is that we're able to work and look a little bit more at the children in front of us and actually meet their needs using healthcare dollars. And so a lot more to come on that. That's more on like a 4-year plan. It's not a full launch this year. And so we'll be hammering it out over time. And then some other things that we're sort of excited about around eligibility. We're going to do retroactive eligibility. So, as this is, I think, important for practices to know that, sometimes patients show up or potential patients show up and they don't have any coverage, and you try to get the Medicaid, but then they can really only get it going forward. So we're implementing a retroactive eligibility where they can actually get coverage for 3 years, looking back for most services, almost everything that physicians do for Medicaid patients. And so that should help fill a little bit of a gap too, where, if a person loses a job and before they're able to get all the way into Medicaid, they did have a gap, and this should help fill that a little bit. So I'll pause there. I think we're sort of at the top or bottom of the hour, of the half hour, and I've sort of just talked at you for about half hour here. So I'll stop sharing so that you can see my face a little bit more, and I'm glad to answer any questions. And it looks like something's landed in the chat.
Thank you so much. Yes, we did have 3 questions that popped up. Question is, when we have a patient that has an auto claim with PIP coverage of $15K, but then has a deductible of $15K, is this billable to Delaware Medicaid?
God, it's like a bar exam question. No, I'm just kidding. So we are a payer of last resort. And so we actually have a whole office called our Program Integrity Unit, and they inside of it have a third-party liability group effectively. And so they will make sure that everything that could have been covered by another insurance pays first at the end of the day. And so the patient has an auto claim with PIP coverage of 50 and then it has a deductible of 15K. It's just billable. So actually like the coverage of the deductible.
Right.
Yeah, I see what you're saying. I don't want to misspeak. Let me take that one back. I don't even want to guess because I tend to get these things wrong. But I'm glad to take that one back and sort of say like up until that 15K, because that's when the insurance actually kicks in and that's when the coverage is. Yeah, I know. Let me write that down. And who asked that? I just see Kathy. Do you have
Kathy
contact information,
Giordano.
Kathy? Or I can send it to Christy if it's a broader question, if other people share it. I can send it to Christy. I'll send it to Christy.
Okay, thanks.
Okay, that sounds good.
Jot
Okay.
it down, Christy.
So our next question is, can you please clarify the difference between SLMB and QMB, as we are having patients telling us we cannot balance bill the SLMB. However, Medicaid doesn't pay either. I believe they are getting bad information from Medicaid reps.
Yeah, so SLMB and QMB are Medicare buy-in programs. It's eligibility for different parts of Medicare. I always get it backwards. I think SLMB is the slim one. I think that's how I try to remember it, and that they only are eligible for A, and QMB is both A and B. I might have that backwards, but I do know it's different eligibility for different parts of Medicare at the end of the day. And so we pay effectively their premiums for that. And so that's sort of the difference, is like their eligibility on the Medicare side, what Medicare services that they're getting. So Medicaid doesn't pay, as we cannot balance bill the SLMB. Medicaid doesn't pay either.
So Drew,
Uh-huh.
it's Cheryl Mangello over at Family Practice Associates.
Sure.
So the problem is that the SLMB covers the Medicare premium, but when they have the Medicare deductible and the 20% coinsurance, we balance bill them. Well, patients are calling Medicaid and they're saying, oh no, they're not allowed to balance bill you. You can file a claim and you can do this and that, but that's not true. The QMBs are the ones that you guys pay whatever, and then we have to write off the difference because you don't cover the whole 20%. You only cover what's customary for you from your fee schedule. So we do have to write those off. However, the slim MBs is where we're having some struggles. And it seems that the Gainwell folks are a little confused as to what they're telling patients, and we're getting a lot of not so nice stuff.
Yeah. I mean, it sounds like there's just a inconsistency in guidance. I mean, we can definitely, I don't know the answer to that, but it sounds like if there's confusion out there, that's something that we should be more clear on. And that's something that we can definitely help with.
I think also if you actually look at the Delaware Medicaid policy and it gives you the breakdown of the coverages, that's really not self-explanatory. It's really hard to read because you're saying like X12, you're not actually giving us what is covered, what's not covered under that patient's coverage itself.
Okay. If you hear me, I'm just jotting a note because I can take that back to our to the Gainwell team as well. And overall, oh, actually, this is reminding me. So overall, one of the things that we're finding is our website sucks. I'm going to be completely honest amongst friends, that we could do a lot better on clarity of what gets out there. Every once in a while, an MCO will point on our website and be like, that doesn't make any sense. But practices sometimes do too. One of the things that we're doing in 2025 is we already have an advisory committee. It's a little defunct. And so one of the federal rules is we have to create a beneficiary advisory committee. And so we are going to, and I would love your recommendations of people that you work with in your populations that you think could give good feedback. But what we're hoping for is to have more of an outside look at things, like on our website, that, are they helpful? Do they make sense? What do we need to rewrite? And then we're also going to recreate our broader advisory committee that the beneficiary advisory committee has to be a part of. And again, one of the things that I'm really hoping that the group can do is sort of hold us accountable on what we're putting out there on information that makes sense. Because I feel like we err right now on the side of being like we've historically been so anxious about putting out bad information that we hew really closely to just like the very close facts that we know from CMS, and then they are not translated well. So you don't get it. You don't actually put information out that people need. And so questions like this are very helpful at the end of the day, is what I'm trying to say. And please do try to get some more information and involvement in those committees, and tell us when something doesn't make sense. So I could take this back and say, especially if you have a link to like on the website, like this doesn't make any sense to me, like just shoot it to me, and I'm glad to have another look at it, because DHSS broadly is completely overhauling this website over the next year. And so we have a window to really try to make it more accessible and useful. see anything else in the chat, but maybe Christy does.
Oh, my mic wasn't working. Sorry. There was another question that came in. Is there a payer? Do you have the payer ID for DMAP? Do you happen to have that?
The payer ID? No, not off the top of my head.
Okay.
But it should be in the portal, that information. If you,
I figured it would be somewhere in the DMAP portal.
yeah.
If not, Lorinda, if you can send me an email and I'll help you figure that out. Last question here is, how are you guys doing with physicians re-registering for Medicaid? Has that been wrapped up?
Re-registering. Oh, the 21st Century Cures. I think that probably means,
Yes.
I'm going to take a guess that they mean 21st Century Cures.
Yes.
So we had a federal requirement, just for everybody's edification. We had a federal requirement that came down several years ago, and then we took a long time coming into compliance, I'll be honest. And the short answer to the question is, yeah, we're done. And what we're looking at now is, how do we make it less onerous going forward? Especially larger practices, but even small practices that maybe have multiple locations. We understand that it put a lot of pressure administratively on practices. A lot of decisions were made before I got here, so I actually think it's a little bit of a design flaw. But what we want to do going forward is try to make it a little bit more user friendly and a little bit more flexible, especially around the locations, so that if you are a servicing provider in multiple locations that or excuse me, I get it backwards, a billing provider in multiple locations, that you only have to enroll once, and maybe with different location codes. But anyway, long story short, we're done with it, but we are trying to improve it because this is going to be an ongoing thing. So anywhere between 1 and 5 years when you have to re-enroll. And so we're trying to use the time wisely to make it a little bit more friendly.
Great. Thank you, Drew.
Mm-hmm. Oh, there's Lynn. Hi, Lynn. Like your background. It's very cozy.
Thank you.
Thank you so much. Another question came in. Will the professional crossover claims submission be changing?
Professional crossover claims be changing. Changing from what? Maybe? Things are always changing.
Oh, they said here for specifically for the secondary claims.
So will secondary claim crossover be professional crossover claims? That's also a TPL thing. So you're saying that it's cumbersome now, can we make it better? Yeah, I would take feedback on that. If you have examples of how it's cumbersome, and you can sort of just give me a little bit more context, I mean, we can definitely dig in and see if we can find efficiencies. Sometimes we can't, because it's a federal requirement that we got to do things a certain way. And sometimes we can. Sometimes we can be like, oh, well, the feds only need this. We're requiring all this. Can we kind of lighten up? And so potentially, but I would have to learn more.
One example, I know Kelly submitted this, but one example would be if a patient has an Aetna Medicare policy. We have the Aetna in as a commercial insurance, obviously. However, Medicaid is forcing us to have it in as an MCO plan, forcing us to have it differently, and updating or adding additional Aetna policies into our system so that the claim filing indicator is equal to what Medicaid wants. And that's probably what Kelly's experiencing, because I know that we too have experienced that.
Okay. Yeah, my guess is that it was that there's a system limitation and they were trying to find a workaround for you to get you from point A to point B. But I can take that back to our TPL unit and overall. So you're sort of forcing it. Okay. Okay, that's helpful feedback.
Thanks.
Thank you so much. I think that was the last question. I want to thank you again for a great presentation, Andrew. It was good seeing you again.
Good seeing you as well. And like I said, as you run into things like this, please let us know. I can't promise we'll fix everything, because we can't, and you should see our to-do list, but we'll do everything we possibly can.
Thank you so much. And if anything does come in that I can send to you, I'll send them your way.
That sounds great.
Thank you so much.
All right. Thank you.
Okay, our next presenter is from CMS. Patrick, are you on? Okay, we can take a short break and I will check in on Patrick. So everybody get your coffee, run to the restroom really quick, and we'll be right back. Okay, hey, Patrick, are you on?
I am. I was on another call. I just got
Great,
an email, so I jumped on as soon as possible. How are you today?
great. Thank you so much. I'm glad you could make it on. Um, yeah, the floor is yours. Screen share is enabled, and you can go ahead and share your presentation.
Okay, I'll just need a second to pull everything up and make sure that
Okay.
everyone can see what I see. So let me just give me 1 second. Okay. Are you able to see just the slides?
Yes.
Okay, you're not seeing the presenter view? Just want to make sure.
No, it's the regular slides.
Okay, great, great. All right, greetings everyone. Thank you for having me today. My name is Patrick Hamilton. I'm with the Philadelphia Regional Office of CMS. I have been with CMS for a number of years, and I used to do this event in person back before COVID days. So I remember traveling down to the Delaware Medical Society in the beginning of January and doing this in person. So this was always one of the presentations I was looking forward to doing. That was back when I was the provider outreach specialist. I moved into the special assistant to the regional administrator role at the end of 2020. And now I am actually the acting regional administrator, as you can see here, at least through the middle of May. So Sharon Graham, who is the regional administrator for Philadelphia, she's been tapped to be the acting deputy director of the Office of Program Operation and Local Engagement. So I'm filling in for Sharon. And then Dexter Glasgow, who is the current provider outreach specialist for Region 3, is on extended leave through through April, actually. So I'm filling in Dexter's place. So he will be back working with the medical societies in the spring. So I'm happy to be here. I'm going to be giving you an update on the latest and greatest in Medicare policy as promulgated in the final rule, and then also some other stuff that you should be made aware of. I'm going to start with our disclaimer. This is a disclaimer that we use for all of our presentations. Just make sure that you know that the information that is in the slide deck was current at the time of the presentation, but of course, that policy is subject to change. Contents of the slide deck do not have the force and effect of law and are not meant to bind you, the public, in any way, unless specifically incorporated into a contract, which we won't be doing today. And the document is intended to provide clarity to existing regulations. So before we get started with the fee schedule update, when we go out and we're talking to our audiences, we like to try to incorporate some of the monthly health observances that are generally celebrated, and then also to inform Medicare services and coverage guidelines that may relate to those health observances. So in January, of course, we're starting the beginning of a new year. So we always like to make sure that folks are aware of that they can get and providers can bill for the initial preventive physical exam, or sometimes it's called Welcome to Medicare. This is a one-time preventative appointment designed to promote health and well-being for individuals newly enrolled in Medicare. So these are for people that are just beginning their Medicare coverage. And it provides an opportunity for these people to review medical and social history, assess their risk factors for diseases, and to provide education and counseling on preventive services. The exam typically includes measurements like height, weight, and blood pressure, a simple vision test, and a discussion of advanced directives. Now, who can get the Welcome to Medicare visit? As I mentioned, people who are new to Medicare, and they have to get it within the first 12 months that they are enrolled in Medicare Part B. And it is at no cost to the beneficiaries, so long as they're going to a doctor who accepts assignment. In addition to the Welcome to Medicare exam, we also have the annual wellness visit, sometimes called the AWV. It's considered also a preventive service offered to Medicare beneficiaries to create or update a personalized prevention plan aimed at improving overall health and preventing disease. So unlike the Welcome to Medicare exam, the AWV is available annually after the first 12 months that somebody is entitled to Medicare Part B. And then during this visit, healthcare providers review patients' medical and family history, assess risk factors for potential health issues, and measure key health indicators like weight, blood pressure, and body mass index. Now, whenever I talk about the annual wellness visit, I always like to make a distinction and make sure that people are aware that the annual wellness visit is not the same as receiving a physical. So there are differences. So in terms of the purpose of the annual wellness visit is a preventive service designed to develop or update a personal prevention plan based on the patient's health history and risk factors that I just mentioned. Whereas a physical exam is a hands-on evaluation of the body to diagnose or assess ongoing medical issues or symptoms. The content of the annual wellness visit includes reviewing medical and family history, measuring basic health metrics, assessing cognitive function, and creative and schedule for preventive screenings and services, and it does not involve a hands-on or physical examination. Whereas a physical exam involves a thorough head-to-toe examination by the doctor, which may include listening to the heart and lungs, examining skin, reflexes, and other diagnostic evaluations. And as I mentioned, the annual wellness visit is a covered preventive service covered under Medicare Part B, so long as they are going to a provider who accepts Medicare. Physical exam is generally not covered under Medicare unless it's specifically related to a specific medical concern or condition. And then any diagnostic tests or treatments resulting from the physical exam could have out-of-pocket costs. So always make sure that folks are aware of the differences between the two. All right, so now to be the bearer of bad news, and this is information news that you already heard of. The rate cut did go into effect, unfortunately, at the beginning of the year. For those of you that follow the news, and I'm sure everybody here does, before the holidays, there was a bipartisan piece of legislation to keep the federal government open that did include provisions that would have staved off the cut in Medicare. That looked like it was going to pass until it didn't. And then on December 21st, I believe it was, there was a continuing resolution that did not include these provisions. So everybody was very disappointed. And again, these cuts are congressionally mandated. This is something that, of course, and you probably know this, that CMS does not have the statutory authority to avoid. So the cuts did go into place. The continuing resolution that was passed is through March 14th. I suspect, and I always say this stuff with the caveat that I do not have a crystal ball, nor do I have a back channel of secret information, especially as it pertains to congressional legislation and congressional affairs. We have no idea. CMS, especially in the regional office, we don't know what happens with this congressional stuff until we see it on the news, just like you do. So I don't have any information to share with you in terms of how this is going to pan out. Other than to say, I do suspect that it will be part of the negotiations that will lead up to that March 14th deadline. I will tell you that there was, and you may know this, a bipartisan bill that was introduced in December called the Strengthening Medicare for Patients and Providers Act that would have tied the Medicare physician payment schedule to the Medicare Economic Index. I am not going to pretend to be an economist and know exactly the ins and outs of how that works. But if you are not aware, I just wanted to make sure that there is bipartisan support to address this. Again, we will have to see how this shakes out leading up to that March 14th deadline. One of the things that kind of flew under the radar, at least it flew under the radar for me, was that the continuing resolution that I'm talking about temporarily extended many of the Medicare telehealth flexibilities that would have expired on December 31st. So I've listed them here for you on this slide. So the geographic and originating site flexibility, meaning that anyone, anywhere, any Medicare beneficiary in a rural, urban, suburban, exurban area can still avail themselves of Medicare telehealth services through March 31st, 2025. That's the other thing. The continuing resolution I talked about goes until March 14th. The flexibilities for Medicare telehealth go through March 31st. So the geographic and the originating sites in terms of where the services can take place, the continued expansion of the eligible provider types that can provide telehealth services, FQHCs and rural health clinics can continue to offer telehealth services. Audio only was not only extended for all telehealth, but also permanently for the telehealth services. And I think I'm going to mention this on the future slide that are permanently part of the Medicare telehealth list. And then also the in-person exam requirements for behavioral health services. They were also extended through 2025. So again, this is part of the continuing resolution. Just want to make sure that you were aware of this. In terms of what CMS, the actions that we can take on our own, we do have statutory authority that are not quite as expansive as the flexibilities that have been put into place since the pandemic. but we are able to add services through a process and through a rulemaking process to either permanently or provisionally add certain services to the telehealth list, which outside of the flexibilities and outside of the public health emergency restrictions that were lifted, allow CMS to include moving forward after all of the flexibilities have ceased. So we finalized the addition of some care training services and also prep counseling services. Also for the telehealth services that are on those permanent or provisional lists. So not the ones that are covered under the CR just until March 31st, but the ones that are going to be part of Medicare permanently or provisionally as they work their way up to the permanent list. We are going to be allowing audio-only communication for those services as well, starting in 2025. So again, those are for the telehealth services that are on the official Medicare telehealth services list. We've also extended for 1 year, and this is part of the physician fee schedule final rule, suspension of frequency limits on subsequent hospital and nursing facility telehealth visits, the ability of teaching physicians to provide virtual direct supervision and virtual supervision of residents when the resident is providing telehealth services, and physicians providing telehealth from their homes. So if a provider is providing telehealth from their home, they can put the address of the facility that they work for instead of their home address. That is one way that we are addressing some safety concerns that we were hearing with that as well. We also finalized 3 new HCPCS codes, G0451, 0452, and 0453 for caregiver training and allowing verbal consent and possible inclusion in telehealth services, as I mentioned. These codes ensure that caregiver training aligns with the patient's treatment plan. Also for 2025, we're finalizing proposal to allow payment for the outpatient or the office and outpatient ENM visit complexity add-on code, which is HCPCS code G2211, when they are reported alongside the OOEM base codes by the same practitioner on the same day as an annual wellness visit, vaccine administration, or any Medicare Part B preventive service, including the Welcome to Medicare exam that I talked about. And the CPT codes that are included are listed here on that slide. And that is for the office or other outpatient setting. The department also finalized payment for advanced primary care management or APCM services in the final rule. The new APCM services are described by HCPCS G codes G0556, G0557, and G0558. And they bundle elements of existing care management and communication technology-based services into a streamlined set of codes reflecting key aspects of advanced primary care, which includes principal care management, transitional care management, and chronic care management. Unlike existing codes, the APCM services are stratified by patient complexity. So level 1 is for patients with 1 chronic condition, level 2 for those with 2 or more chronic conditions, and then level 3 are those with 2 or more chronic conditions, but they are also deemed to be a qualified Medicare beneficiary. The codes incorporate requirements such as consent, 24/7 access, care continuity, comprehensive care plans, care coordination, enhanced communication, and population level management. I also increased the valuation for level 1 in response to comments that we received, and we may revisit valuation for the other codes in future rulemaking. The final rule also includes several provisions to enhance access to behavioral health services for people with Medicare. Notably, we established separate coding and payment for safety planning interventions, finalized as HCPCS code G0560. This code, which is billable in 20-minute increments, is intended for services personally performed by the billing practitioner, focusing on developing strategies to mitigate potential crises such as suicide. Additionally, we introduced HCPCS code 0544, which facilitates payment for a bundled service comprising 4 post-discharge follow-up contacts within a month. And this is for the aim of ensuring continuity of care for patients transitioning from hospital or emergency department settings following a crisis encounter. We've been doing a lot of expansion, although it's probably incremental, in terms of dental and oral health services. Dental and oral health is one of the 13 cross-cutting initiatives that the agency has been working on over the past 4 years. In the final rule, we finalized provisions that impact dental and oral health services, notably expanding coverage to include dental or oral examinations and necessary diagnostic and treatment services for patients with end-stage renal disease who are undergoing dialysis. This particular coverage applies to procedures performed in both outpatient and inpatient settings, encompassing Medicare beneficiaries receiving hemodialysis or peritoneal dialysis at home or in an end-stage renal dialysis facility. We also solicited comments on potential links between dental services and treatments for diabetes, autoimmune disease, sickle cell disease, and hemophilia, and we continue to engage with stakeholders to redefine or refine those definitions. And then there will be 2 new policies that will be implemented and go into effect on July 1st of 2025, requiring the KX modifier on claims for dental services linked to covered medical services to enhance claims processing and program integrity, and also mandating the inclusion of diagnosis codes on 837D dental claims to align with statutory and regulatory requirements for physician services. We also finalized updates to colorectal cancer screening coverage by removing barium enema, which is considered an outdated and rarely used screening method, and expanded coverage to include computed tomography colonography, or CTC, and Medicare-covered blood-based biomarker tests. So these are similar to stool-based tests, in that a positive blood-based biomarker test will lead to a follow-up screening colonoscopy without beneficiary cost sharing. We're also revising regulations to clarify that frequency limitations do not apply to follow-up colonoscopies within the context of what is called a complete CRC screening. These changes aim to enhance access to early detection and prevention, particularly benefiting rural and underserved communities disproportionately affected by CRC. The final rule also has a lot of updates for the Medicare shared savings program. Comprehensive updates to advance value-based care, promoting health equity, and ensure program sustainability. There is a new prepaid shared savings option that allows high-performing accountable care organizations to receive upfront payments for investments in care coordination, staffing, and infrastructure enhancements. To address disparities, CMS is introducing a health equity benchmark adjustment, and that is to incentivize ACO participation in underserved communities by reducing financial barriers. Quality measure reporting is streamlined by aligning with the Adult Universal Foundation measures, emphasizing digital reporting for consistency and administrative efficiency. And we're also adopting safeguards to improve financial accuracy, including methodologies to exclude payments from HCPCS and CPT codes identified as suspect. All these updates are part of our broader strategy to reduce health disparities, improve care delivery, and achieve its goal of enrolling all traditional Medicare beneficiaries in accountable care organization agreements by 2030. So that is just under 5 years from now. So we will see what happens with that. We also have updates to the quality payment program in 2025. We are maintaining stability by keeping the performance threshold at 75 points and the 75% data completeness criteria through 2028. So that will be for the next couple of years. We're also advancing the development of the MIPS value pathways. There will be 6 new MVPs this year for specialties that include ophthalmology, dermatology, and gastroenterology. Additionally, the alternative payment model performance pathway, or APP plus quality measure set, is finalized, and that will be required for Medicare Shared Savings Program ACOs starting this year. So if you are an MSSP ACO, then you will be required to do the APM quality measure set. The APP Plus set includes 11 measures, including 6 existing measures and 5 new ones, again, from the Adult Universal Foundation measure set, which I mentioned a little bit earlier. In addition to these policy changes, we also updated the measure and activity inventories. There are 7 new quality measures. We removed 10, along with making substantive changes to 66 existing measures. We also finalized 6 new episode-based cost measures and revised cost measure scoring to better assess clinician cost of care. The 7-point cap on certain top-down quality measures is removed. And we're also revising policies for promoting interoperability performance, categorized by streamlining reporting requirements, and for improvement activity. Those activities up until now have been weighted. That weighting has been removed as well. And then I also want to make sure, just changing gears, going away from the final rule, make sure that folks are aware of some of the benefits that are going into effect in 2025 directly as it relates to the Inflation Reduction Act. So everyone, I think, is familiar with the Inflation Reduction Act. There were a host of Medicare provisions that greatly impacted specifically people with Medicare Part D. Things like, excuse me, the cap on insulin, the $35 monthly cap per insulin product that's covered by Medicare, which started a few years ago, free vaccines. There was also out-of-pocket cost and some other things. This year, for the first year, all people with Medicare Part D will have a cap of $2,000 on their out-of-pocket costs. So this greatly reduces out-of-pocket spending for people who are on Medicare Part D. If you remember going back to 2006, 2007, when Medicare Part D was set up, there were all these different levels. There was the donut hole, there was catastrophic coverage. That has basically gone away. So that when somebody hits $2,000 of out-of-pocket costs in a calendar year, then they no longer pay anything over $2,000. So this is a huge, huge deal for people with Medicare Part D. Also starting this year is something called the Medicare Prescription Payment Program. And what this program does, this is a voluntary program, and it allows people who have especially high out-of-pocket costs in the beginning of the year to spread out those predictable costs over the course of 12 months. This is not a program that is a cost savings or a cost reduction program, in that it does not reduce your costs or you're not saving anything or there isn't a discount. But what it does is it calculates your predicted cost for your covered Medicare Part D prescriptions. And depending on when you start in the calendar year, spreading those out over 10, 11, 12 months. So for folks who have a lot of high out-of-pocket costs in the beginning of the year, they can avail themselves of this opportunity to enroll directly with their drug sponsor, with the plan sponsor, and they are billed separately for those out-of-pocket costs that they would be assessing. Again, this is not for everybody. There are some folks that may be getting extra help, so their out-of-pocket costs are not going to be high, or they would be spread out throughout the year for other reasons. But this is something that people with Medicare can find out if they are qualified, either by contacting their plan directly or by going to the point of sale to the pharmacy. The pharmacy will get a message through the system that the person who is at their counter could benefit from this program based on their predicted out-of-pocket costs for 2025. And then the pharmacist would give that person the information about the program. The person would go home and they would sign up directly with the plan. They cannot sign up, unfortunately, at the point of sale at the pharmacy. So we want to make sure that people are aware of that. There has been a lot of work behind the scenes to set up the infrastructure to make sure that messaging goes from the plan to the pharmacist, to the beneficiary, and then back to the plan as well. So that has been put into place starting in 2025. So that is what I have. What we do at the end of all of our presentations is we ask you if you could just take a quick second and either snap with your phone the QR code that's here, or I'll be sharing the slide deck after the fact and you'll have access to these links. If you could just give us some feedback in terms of evaluation. What we do after we do all of our presentations is we want to make sure that the information that we are imparting to you is information that you need in order to do your jobs better and to share with your partners and the people that rely on you for Medicare, Medicaid, and marketplace information. So any feedback that we can get is greatly appreciated. I will leave this up here just for another second or two. And the most important slide in the slide deck will be coming up. That's my contact information. Always feel free and I have to update my title here actually. But the most important thing is my email address and my phone number. So if you have any questions after we depart today, do not hesitate to reach out. I will tell you right now, I usually do not have the answers to your questions. But I can, in all likelihood, get you to the person who does have the answers to your questions. And I will stay on and try to answer any questions you may have. I will probably frustrate you because some of the questions you may have about what's going to happen after next week, I don't know. We're waiting to see what the direction and what the priorities are going to be of the new administration when they come in. So we will be waiting with bated breath just as you are. But feel free to reach out if anything or any issues come up after we depart today. So with that, if there are any questions, I will try to entertain them now.
Thank you so much for your presentation. Great information. We did have a few questions that came in. Question that came in is regarding telemed. To date, almost no insurance or commercial and Medicaid will reimburse telemed. Will the new policy start to enforce reimbursement, or will it continue to be up to the payer?
So it is going to be up to the payer. So usually, the policies that were extended by Congress specifically relate to Medicare, to the Medicare program. So the Congress, we do not have the authority to tell payers that they have to accept telehealth. I know personally, my healthcare provider, they stopped telehealth appointments, I think, at the end of 2023, and that was a surprise to me. So to the extent that it is true that that other payers take Medicare's lead, that will be up to the payers to determine if they're going to do that. But the legislation that we're talking about, the flexibilities specifically relate to Medicare.
Thank you. Does anybody else have any other questions? Okay. Well, thank you again, Patrick, for the great presentation.